formal meeting, which is the 5th of July. Are they okay? I've noticed a mistake. No, I didn't. Kevin did. To be honest, he read them far more closely than I did, which is we had the people who were independent non-execs and partners as only in attendance. They are actually members of the board. So can we alter that going forward, please? Any others?
And I did send my apologies to.
Oh yeah, you said your apology. You see, when you're not here, everyone else was in attendance, Kevin. It was clearly all around. It's all about you.
Well, know that.
Okay.
Confirming what I already knew.
Anything on the action log that needs reviewing? I didn't see anything. Pick up. No. Okay. I'll take silence as a sense. Storytelling. Christine, you can do the introductions.
Yes, please. Yes, thank you, please. So I'd like to introduce Brigitte Caviani, who's our Head of Health and Wellbeing for South Yorkshire. Brigitte and her team have done a huge amount of work helping internationally educated colleagues settle well in South Yorkshire and the organisations that we're in, working with everybody across organisations to do that, and indeed across North Eastern Yorkshire. So I'm sure Brigitte will tell you about that. And we're delighted to welcome Dr. Issam Ghariba, who is here to tell you something about his own particular experience of coming to work in South Yorkshire. So I'm going to hand over to Brigitte.
Thank you very much.
Brigitte, welcome. Lovely to see you.
Thank you. So I'm just going to go through, give you some context first to the recruitment in South Yorkshire. And then I'm going to go through about the support that my team and I have been giving the international. So just in context, international recruitment is not new in the NHS. It's been a long time. But in 2019, we started looking at collaborative recruitment activities, not just mainly in the NHS trusts. And that's just to take you through the journey. I'm not going to go through every line, but from 2019, we started recruiting 650 nurses that came through. So nurses, few midwives were initially recruited through structured programs where we had trusts going to the different developing countries and recruiting them to come here. 21, we started looking at AHPs, mainly focusing at occupational therapists and diagnostic radiographers. In 22 last year, we started a program called the South Yorkshire Restore Program. We were looking at supporting UK-based refugees. And I'll talk a bit more about refugees later on. And the same year, the HE published the Global Radiologist Program. This year, we got funding. The funding has been received to start looking at recruitment of international colleagues into adult social care. We know there is a project that is starting in Yorkshire and Humber, and as yet, South Yorkshire is to commence that program in social care, much needed. In 23, I talked about the Restore program. With the South Yorkshire Employability, Pastoral and Retention programs, we were able to support 18 refugees into non-clinical roles, mainly in Sheffield trusts. And it's still not out yet, it's hot to the press. There's going to be a large-scale refugee recruitment event taking place in Sheffield in November this year. 3 cities have been chosen: London, Birmingham and Sheffield, and myself and Ben Chico, who leads on supply and growth, are heavily involved in the planning of this. So although we're recruiting a lot, what is so important is we need to retain them. We are aware that our international educated colleagues are being contacted by New Zealand, Australia and Canada to actually snatch them away from us, and we need to stop them doing that. We need them to be happy. We need them to be, because when one comes, they bring their family as well. So it's important we actually support them, and we want them to stay here. I led on a 12-month project funded by NHS. It was funded in July 22. Each region, each of the ICBs in every region were asked to submit a bid, and we were successful in South Yorkshire to do that. And I led myself, and we've got 3 of us in the team, so it's health and wellbeing and retention team led on that. We involved the EDI leads with that journey, and we involved the Stay and Thrive regional team as well with that. We did this project, but it wasn't just NHS Trust. Just as Christine said, it was all sectors were involved in this. It was the first NHSE inclusive health and wellbeing project led by one ICB for the whole region. So it was quite different. I'm going to give you a short snapshot about the project. I have forwarded the document, more details about that. If you are interested, that will come through to you. So what we wanted to achieve with that, initially, what were the 4 integrated care systems in North East and Yorkshire, we needed to test out by increasing the international educated health and care staff knowledge about what health and well-being offers were available to them. We also at the same time wanted to increase the well-being leads and line managers' knowledge about the confidence about supporting our internationals. As I've already said, it's so important that we wanted to support them. We want them to settle, stay well, and we need them to be productive and retain them. We had a range of activities during the year, and some of you in the room were involved in these. We asked them initially what they wanted, so we were able to contact as many as possible within the whole region. Asked them, we didn't want to create anything new. We wanted to know what we already had, but we wanted to know from them and the line, was there anything specific that might actually help them as well? We gave them the opportunities to come together, virtually and in person. We created, we knew one of the things that came out, there was an interest in setting up a buddy system. They wanted to be connected to others and get different support outside their work. We also at the same time gave managers and staff opportunity to share tips, because the different organisations came on board at different times with recruiting internationals. Sheffield Teaching Hospitals was one of the first. And very recently, Sheffield Health and Social Care Trust, where the last one came in. So there's a lot of learning from the ones that have already been recruiting people, what's worked, what we do. So sharing was really important. We needed to understand needs and barriers, and what they told us through interviews, through surveys, focus groups. We did that in the first 3 months of the project. They told us they wanted to speak to other internationally educated staff. Some of them wanted to speak to people from their own countries, because some trusts there was one trust that's got 35 different nationalities, and that's a lot. Our largest numbers are coming from India and Philippines, but some are coming from many different countries. So they wanted to speak to others. They wanted to engage with others on an ongoing basis, not just as a one-off in an event. They wanted to network with people. They wanted to understand the cultures and ways of working in the UK. So it's not just how we actually work here, but also clinically. It's so different working in different health organizations, different countries. They wanted to know what it was that can help them on their way of working. What was normal for health and well-being, to take advantage of our well-being. Rather, it wasn't a weakness. It wasn't stigmatized. Mental health is sort of expressed in different ways in different countries. So we needed to make sure that actually it wasn't a weakness to ask for help, and it wasn't stigmatized, and we could signpost them as well. Thank you. We built a community of practice by doing these things. We had something called Connect Club. It was bite-sized sessions online. We asked them what they wanted. Not surprisingly, financial well-being came very high, and we had 2 sessions of those. That is one of the biggest struggles they have. I'm happy to answer questions on that. We had a large-scale face-to-face gathering last September, and this was championed by David, our Chief Medical Officer. He attended that to support it. In that room, we had 28 different nationalities. So that was really interesting. They talked about loneliness. We arranged Saturday wide wellbeing events, walking activities with families. They could bring their children and families. And there was a webinar as well arranged for them. And we had the different ICBs leading on a lot of the webinars as well. Again, financial wellbeing. What we did in person, we did bring them together. I've mentioned about the September event, and on this slide, you're able to see some of the comments that they've actually said at it. We did a short survey at the start of the event and at the end of it to just find out if their knowledge has increased as well. 100% of them said that the event did help them learn more about health and well-being. We tried to do it, it's called Welcome to South Yorkshire. We thought we could give them, we served them food from some which had pie and peas. Some of them wanted Indian food. But so that was introduction to our culture here with the pie and peas. And that went really well for the majority, but not all. We wanted to upskill managers. I did say that that was really important because the line managers and those supporting them in pastoral support, they are the first in contact with them. They are there with them in work. We arranged a virtual sharing session for them, and we had 3 of those in total. And the face-to-face one, that was, I would say, that was about April, May this year. And this was championed by our chief nurse, Kathy. She attended that event and talked on it. And that was the opportunity for all the 7 trusts to actually present what numbers they had, what was the challenges, worked well. And I have to say, everything they were saying was absolutely amazing. And they were doing things, and now they continue to share things. And lastly, we put on 20 line managers to do a course about culture competency. We've got the trainer program that now will continue in 2 organizations. So next steps, a lot came out of it. We would like to continue doing with this project. It was a very small, but it was an ambitious project because it was led across the whole region. Certainly 3 out of the 4 ICBs are continuing to drive that. We meet regularly to discuss what we're doing. Humber and North Yorkshire, they've got somebody in the ICB with international educated colleagues in their job description, so they're taking very seriously, and North East, North Cumbria. We are continuing to lead my team on now the project with refugees, but continue with our previous project. We have got a website as well. Thank you. And I can share that link with you, and it's got all the information from the last year, all the useful resources. And we have got, we had a tips booklet, a digital copy. Now this is now sent out by all the trusts, or anybody, sent out to anybody before they even come to the UK, so they can understand. There's all the dialects of South Yorkshire in there. Those of you who live in Sheffield, you've probably seen these bins, the picture of the bins. I'm not sure that's helping with getting them to understand our language. Put it in here is definitely in the booklet. I think the dialects is very hard for them, but actually I even struggle after 45 years here myself. I'm going to hand over to Dr. Issam Gariba, who I've been working with only in the last 5-6 weeks, and I want to just get him to speak to you about his journey.
Yeah, stand up. Yeah, of course you can.
I'm sorry, but from our world, our meetings, we always do our meetings standing up.
You stand up.
Sorry. So yeah, hello, my name is Assam. I'm a doctor by trade. I was born and raised in the UK a long time ago, but in the south, in London. What else? I've got my medical. I've lived here. I was born and raised here, but we left when I was quite young. We moved around in Libya, Tunisia, I remember Switzerland as well. I've got my medical education in Egypt. That's where I graduated. That's where I did my basic foundation year training and did a little bit of A&E. And we do our meetings standing up. So yeah, came back here to the UK December 2020, right before the lockdown. To arrive here, I was planning to do a clinical attachment in Doncaster Royal Infirmary, do the PLAB 1, PLAB 2 exams, get into the track to the system and start get a job and get on with my life. But the lockdown came, everything got complicated. The situation just deteriorated really bad. Situation in Libya as well got really bad. So I ended up in a situation no money, no support. I had to resort to claiming asylum. Uh, uh, I was in Lancaster during that time. I got involved. I started volunteering in multiple organizations. Still running out of money, still no guidance. I had to claim government support. They picked me up and serendipitously, I hope I pronounced that word right. Yeah, picked it up. They picked me up and got me here to Sheffield. I was very lucky. I'm staying in one of their hotels. Big emphasis and big quotation marks. It's called a hotel, but it's not the Marriott. It's not the Sheraton. It's the worst Travelodge stayed in multiplied by 100. It's really. So yeah, after I got here to Sheffield, started volunteering with City of Sanctuary. I was supported by great people in Lincolnshire. They're called the Lincolnshire Refugee Doctor Project. They've helped me with my medical exams. I'm 90% done with my medical license. I just have a small test if I can take, and I'll get a full GMC registration. So always almost there. After a year of waiting, I've applied for. Yeah, after a year of waiting, you were eligible for something called shortage occupation work permit. I call it the Faustian deal. I applied for that work permit. After a couple of months, I've had it. The problem there is once you get the work permit, then I had to go to get the national insurance number. Then I had to go online. Then I had to apply for jobs. Unfortunately, I was on my own. No support whatsoever. Only by stroke of luck, a good chance. There was a NHS job fair in the Winter Garden. I've met Dr. David Black over there, and took his email, sent him an email. He referred me. He referred me to amazing Brigitte over here. He referred me to Michael, Blurt Up, and all these Ben Cheaper, all these amazing people. Just sent me emails, and honestly, the amount of help that they've got me was amazing. I couldn't believe it. Through their help, I was able to get a job. I've got a bank, healthcare clinical support worker, part of NHS Health and Social Care. Finally got myself a job, and the main point is you have a renewed sense of autonomy. You got a job, it doesn't matter how much pay, it doesn't matter what it is, it's just back in the field, you're back to work. Even though I have this job, despite what's going on right now, I'm sure you've seen what's going on in the news, and that situation's getting worse and worse. So yeah, I think am I going good on time?
You're grand. You're grand.
Sorry, I don't want to take too much.
Yeah, you're grand.
Finally, the reason why I'm here this morning is I'm a case study of. I come from a relative privilege. I was born and raised in the country. I've been having beans on toast since I grew up watching Thomas the Tank Engine. I'm a golden Olympic medalist when it comes to ticking boxes and reading government websites. Let's see, what else? Good at paperwork. I have the degrees, I have the certificates, and I'm struggling. Imagine somebody who doesn't speak the language. Imagine somebody with a family, somebody from a marginalized community, somebody with mental health issues. So yeah, that's it. Hopefully, am I good in time?
Yeah.
That's the whole message, and I hope you can keep. If you have any questions, I'm more than happy to answer it. And sorry if I took so much more time.
That was great. Thank you.
Oh, thank you.
Really good. Anybody got any questions? I mean, one of the things that struck, I was about to finish with where you start with where you finished, which is it's been very difficult for you to get where you are, and actually you had so much more going for you than most of the refugees who come into this country. Actually, that says something about how do we reach out in a different way? Because actually, you were also very self-sufficient in going to things and trying to sort stuff out. I think a lot of our refugees wouldn't even know where to start, and that's quite sobering for me. And actually, we're sitting here with real vacancies in the NHS, which is something we've talked about generally. Anyway, there you go then.
Thank you. Both amazing, really good. I'm just in going through this work. Have we got a sort of body of evidence and understanding of where we can influence other bits of the government firmly? I'm trying not to make a political point, but I'm teetering on the edge of it. I think there's something about really understanding these are the Home Office processes that don't work. these are the DUP processes that don't work, because candidly, unless you're really skilled, navigating that infrastructure is nigh impossible. And I say that as somebody who's probably from an even more privileged position than yourself, sir, in terms of it, that's hard work. And I just wondered if, whilst going through this work, which I think is commendable and it's absolutely what we should be doing, we need to have some touch points there to say these processes just aren't fit for purpose. I was more cautionary in my choice of language than I could have been using the expression fit for purpose.
That's a really good point. Leslie?
Yeah, I was just interested in how you're interacting with kind of voluntary sector organisations that support refugees, and you know, is there an opportunity there? Having just had experience myself in the last kind of year and a half of working of supporting somebody from Ukraine, I know that there's a lot of people that are getting support from organisations like the Refugee Council, but still struggling to get into the system. And obviously language barrier is one of them, but also shifting what qualifications are required, people coming with lots to offer, but actually not able to get on the ladder, as it were.
Yeah, I can answer that. I think the project I did was for the ones that have come through different structured programs, and some of them are struggling.
Yes.
They're struggling because of, we need to learn about their cultural awareness, but also financial well-being. Some people are not aware through the Home Office and different government rules. They cannot access childcare benefits. So usually in a lot of those countries, our families look after the children. Here, they're suddenly on their own with extortionate childcare costs. They cannot study at master's level because of their visa status as well. So they're the structured ones. As far as the refugees, there's a massive project going on at the moment. It has started in other parts of the UK, like Lincoln with the doctors, but in Sheffield, it's about to start. So we've got this massive event. It's involving all voluntary sectors. We don't have the date. We're supposed to find out the date this week when it is. We've been asked to really contribute to it. But it's going to be a big event, and it's going to target, in particular, they're saying, those from Ukraine. But those from Ukraine, there's a big language problem, because I've actually been sort of supporting some Ukraine, Syrians, and those from Afghanistan. And we do know many of us come from medical or clinical background as well. We do need these. We need them to work in our organisations. So the investment in refugees is about to suddenly hit South Yorkshire.
Kevin?
Thank you, Chair. Thank you both for that. Given your collective and different experience and knowledge, in the context of the powers that or influence we've got, what more do you think we can do as in South Yorkshire?
Yeah, I think during the project that I've done, I've been very glad that David and Kathy have been very, very supportive and attending the events. And, you know, we have had other directors attend them. Christine's been very supportive. I think when they see there are people who are in higher positions, people in the ICB, and they hear about the ICB, a lot of people go, what is the ICB? Well, we talked to them about it. I think that gives them a bit of hope that there is something that's going to be done. We talked to them. Loneliness was an issue that came out, big issue, and unfortunately we've had cases of sort of suicide, but loneliness was something at Christmas time. So sort of I've got the heads of chaplaincies to work with a lot of the international. So there is a lot of work being done. More work. I think we need to have somebody to lead from the ICB with internationals. I'm not saying it's me, but I'm saying it's got to be in somebody's job description. That is something missing. We've got the recruitment, and my team does the support and pastoral, but that's for everybody. So I think we want them to stay. Huge investment has been made in recruiting people to come here, and we do need to make sure the refugees are supported. And once this big event takes place in November, it can't be just a one event. It's what happens afterwards.
I've got Lisa, then I've got Jahida and Kathy, then Joe. Okay, Lisa.
Thank you so much for sharing your story, and thank you for all the work that you're doing. And I think it is important to get buy-in from the system. I think moving on to retention, we have quite a few medical graduates in primary care, So we're recruiting more and more. And we found that it's really useful to have sessions with all of our staff, explaining some of the issues that they face, some of the cultural differences, just raising awareness so that when they come into that system, they've got that support and that understanding, because sometimes they're not really welcomed because of the differences. So I think raising that initially really, really helps. Is there a place to do that in the trusts or wherever else they're working?
I think there's a lot that they're doing that can be actually transferable. Certainly the project, I'm happy to share what other trusts have been doing. And we had an event where everybody shared. One trust has got a career coach, and that was needed because it's okay coming in as band 4, but we need them band 5. We need them to progress to band 6, 7 and go up in their career. We did have doctors from primary care at one of our events. They managed to find out about it through Twitter, and we reach as many as we can. There is a lot that you can learn from what all the trusts are doing, some amazing work that we can share with you.
Shahida Zenkas.
Yeah, thank you both so much. I think everything that you've said and done is so commendable, but actually it's a continuation of an ongoing story that's been around for a very long time within the refugee sector and then the wider marginalised communities. And I just wanted to reflect back that, for example, in Sheffield, 25% of our ethnically diverse population, by the year 25, it'll be 25% of the whole population. But of that 25%, 40% of that population work within health and social care, of which a significant proportion of them are from the refugee communities. Now, the reason I raise that point is because some of those communities are long-term established communities. They've been here for generations, and some are newer arrivals trying to reconnect with existing communities that are here. You talked about loneliness, friendship, embedding into cultures, knowing where you can get your own cultural world food, for example, and all of that kind of stuff. That's all really important. But just kind of picking on Lisa's point about how do we welcome people, how do we retain people, and at what point do we see our international colleagues or colleagues from within the refugee sector as citizens and part of our city and our place? Because it can't just be, well, we can't have an extractive relationship with people, which is, oh yeah, great, we want your skills, we want your knowledge, we want you to come and work within the system. But actually, my argument is we want more. We want you to belong to, to South Yorkshire. You're a citizen of South Yorkshire. And I think there's something really important about that. And I think just one really quick point that I want to make is, in order to retain people, we have to offer them something authentic and meaningful. And it goes back to Kevin's point about what more could we do as a system. So you've touched on leadership, but I also think for an ICB, we have a really crucial role to play in the wider sector, not just the VCS, the private or the public sector. I think we have a much wider role to play because there is a natural synergy of people wanting to work within the health and social care sector. And I think we've got a role of advocacy in there. And what I mean by that is standing up for people. We've seen, again, a bit like Lee, don't want to get political, but we've seen the backlash against refugees. We've seen the backlash against marginalised communities. We also know the impact when we're talking about employability, skills and jobs. We've all heard that term, would have here to take my job. Well, no, not really, because you haven't got the skills, but let's get you skilled up as well. So there is something about how do we balance all of that? So I think everything that you're doing is absolutely commendable. And in some ways, you prove the project that you're doing is proving a point that people have been trying to make for decades. If you invest in the infrastructure and invest in the people that have got those skills, you get the rewards from it. So I think the question is, to me, is how do we advocate around that as an ICB? I think it's going to be really crucial, because I can see this project upscaling and replicating. It's whether we're brave enough to do it.
Actually, Cassie and then Gavin.
Yeah, probably quite an important policy speaker. Always, always Miss Shaw said just before. I mean, some amazing work going on across South Yorkshire. And I'd echo what Brigitte said. Our organisations have really kind of taken the mantle on this and really trying to make sure that we've got conducive environments where people are welcomed, but also where they want to stay and work. I think, Brigitte has pushed, and I push the kind of refugee work both regionally and nationally as an alternative to kind of international recruitment and recognising that we've got people in the country that actually need supporting and have got the skills and need the support to navigate the processes that we've got. So I think this is the start of a really good opportunity. I think we've been really lucky to be chosen as one of 3 areas across the country, and whilst it's based as a Sheffield event, that's because nationally that's been chosen as one of the 3 major cities. So they've got one in the north, one in the Midlands, one in the south. And certainly, you know, Wendy challenged us at an exec meeting around, you know, this being about health. But I think, although it's coming nationally led, it's nationally funded, we try and recreate within that what we need for the workforce for South Yorkshire. And Brigitte, there's just something in there, and it kind of struck me with listening to Sam's story, but I've heard others, is that bit about making sure we've got trauma support within the work that we're doing and the wraparound that we're doing. And that's where I think the voluntary sector play a really key part in that, because most of the refugees that we're supporting into workforce have gone through a really difficult journey. And certainly my learning from being in a provider organisation where we brought in 6 refugees that were in camps in Syria and in other places with no documentation, no birth certificates, no kind of university certificates, that actually the trauma that they'd experienced as part of their journey just before getting into the UK, they needed support with that to integrate into the workplace, and that's the big key part for me that shouldn't be forgotten.
Thanks, Kathy.
Thanks, Piers. I mean, the first thing to say is just to thank particularly Dr. Gariba. I thought your story was incredibly powerful and moving. And I think there's a lot of people in this room kind of are in admiration of your perseverance and what you've done in response to what is clearly a very difficult set of circumstances. So really appreciate hearing that today. I can't help but think that this conversation is central to what we're trying to achieve as an integrated care system. You know, we know that there's large levels of economic inactivity within South Yorkshire, and that's often in minoritised communities, or whether that's asylum seekers or established minoritised communities, or indeed people from deprived neighbourhoods. And we know that having access to good employment and paid work is a critical part of people's health and well-being. So this isn't a sort of peripheral issue. This is absolutely core and central to what we're about. I can't help but think that there is an opportunity. I was going to mention it in my briefing around the NHS workforce plan, which is a huge programme of I guess securing the necessary skills to support the NHS. Now that's only the NHS, so it's pretty much wider than that, but there is an opportunity there. And I think one of the challenges for us as the NHS, I think, is how do we use that opportunity to provide access to people from those communities. So it's not just people with existing skills like Dr. Gariba, but it's also people who you know, have the potential to develop skills. So how do we use that opportunity to reach out to our minoritised communities, our deprived neighbourhoods, to bring people in, because that's central to delivering the aims that we're committed to as the ICB.
Thanks, Kevin. Emma, and then Wendy.
Yeah, just 2 quick points. One is, obviously, I've spent some time with City Sanctuary in Sheffield and see the amazing work they do. It's fantastic, but, you know, it's horrific what people are going through, as you say. And I think 2 points to me. One is we can do all the things, the great things we can, but without some changes to policy from the Home Office, we are not doing the best for our people. And so I do think, as an ask, we probably need to think about how we can influence that, because we can do all the things in the world, but the benefit system, the housing system, they do not stack. It does not support people, and we need to think about how we do that. The second thing, the practical thing, is each of our partnership board members have buddied up with somebody. So Kirsten Major has actually buddied up with Chief Exec of City Sanctuary. So again, we're trying to bring her experience as Chief Exec of our major hospital. Again, how, you know, it's not just about partnership board, it's about how we play a role in terms of that workforce element. So I think that's really positive in terms of practical actions too.
Thanks, Emma. Wendy, and I'm going to finish it, Wendy.
Yeah, thank you, Chair. So there's something for me really about, you know, I'm going to say the role of local government in all of this, really, but just on the issue of roles and asylum and migration. We know that there's a leadership of executive asylum and migration, so my thoughts about how do we take the insight that we've learned through all of this really great support and work that's taking place, really. How do we share that within
how, and because he is the individual that's got a really strong leadership role in there. He is actually meeting up with policy leads from the Home Office and others to influence policies on outcomes and the same. So maybe there's just something about maybe helping brokers and that won't happen to do that. And then secondly, I just wanted to talk about the role of counsellors. So I remember talking to some of the individuals on here, certainly from some of the individuals that are working in Barnsley Hospital, who were saying how they felt so lonely, how they really didn't feel that the neighbourhood within which that they were living was very supportive at all. And actually, and they were really thinking about whether or not, you know, Barnsley would be a place that they would stay. And it was really important then to start to really connect those individuals with people who had a leadership role, and that's counsellors that have got a leadership role around developing warm, welcoming, safe communities, really. So there's just something for me about the role of counsellors in amongst all of this, and how do we get them to step into their leadership role in terms of supporting people of all sorts of different skills, knowledge and abilities to feel welcome on the streets and neighbourhoods.
Thanks, Wendy. Bridget, thank you very much. Really good. The one thing I would want to say is we need you. This is not about, we play this too often as acts of generosity. This country is a better place. When people come in, we make them welcome and we integrate them into our work. We need you, not the other way around. And this is not acts of generosity. This is making us a better people and a better place. Really helpful conversation. Bridget, thank you for your work. It's grand to see you. Really good to see you.
Thank you very much.
Thank you for your time.
I decided that I won't follow that, so I've got nothing to raise under the chair. I thought actually my chief executive should follow that directly.
Notes to hand now. So thanks, Chris. You've got my briefing as usual. So there are a few things that I won't focus on. So things like the joint forward plan, which I mentioned, but we'll focus on that later. We've got updates from place, but the exec place directors will share some thoughts on that. But there are a couple of things that I did want to pull out, and I think the first is really just to reflect on the events at the Council of Chester Hospital and the conclusion of the trial and sentencing of Lucy Leffey. And I think if you work within the NHS, and I think most of us are compelled to work within the NHS because we feel a passion to try and improve people's lives. And I think as those events have unfolded, I think you just can't help but be appalled and slightly at a loss, really. But nevertheless, I think there is an opportunity here, although clearly a horrible set of circumstances. There is an opportunity for us as leaders within public service to learn from the events that have happened, and I welcome the establishment of a statutory inquiry because I think, I suppose like many of us, I mean, our knowledge of the case is through the media, but I suspect there are much wider lessons and for us to learn. I think just to make a start on that, one of the things we are engaged in is a conversation with our particularly our provider organisations about their arrangements, particularly around encouraging colleagues to speak up if they have a concern. And I've had a really strong response from organisations in South Yorkshire describing how they were sort of reinforcing their arrangements, but also in terms of learning from incidents and also aspects of the kind of fit and proper persons, tests around who is able to take up positions, particularly on the boards of statutory organisations. Clearly, we'll continue to work in this space, and obviously as the statutory inquiry unfolds and the learning emerges from that, we'll respond. We've got strong governance arrangements. I mean, specifically related to maternity services, we've got, I think, a strong local maternity and neonatal services partnership, and I think we've got Richard here, Chief Executive of Dr. Malcolm Richard, and Kathy, our Chief Nurse, is active in that space. So I think we look to that structure, particularly with its oversight role across those services. But I think it's more wide. It's more wide than that, and individual statutory organisations will be thinking about this very carefully, but through our own processes including our quality governance arrangements across the ICS. We'll be using those mechanisms too. So I think it's really just to give a sense of that. Clearly, this is something we will come back to in more detail as a board as the statutory inquiry unfolds. So I just wanted to mention that. I guess just a reflection in terms of industrial action, and we continue to experience that. And you know, I think we continue to respond well to that as a system. But we've seen the further dates from the junior doctors and consultants being published over the last few days, and there's a sense of escalation. We're seeing consultants and juniors taking industrial action simultaneously in later this month and into October. So I think that continues to challenge us as a system, and we continue to manage that. But there is an impact on planned services, so not just elective routine surgery, but also cancer care and other planned services as well. So it's not without its consequence, but we continue to manage that. I've mentioned the long-term workforce plan, which has been published since our last formal meeting. It's hugely welcomed in terms of, I mean, I've not seen in my time within the NHS, which is perhaps longer than I'd care to mention. But this is the first time we've had a kind of financially underwritten plan, I think, to take a long-term view in terms of the development of the NHS workforce. And as I just mentioned, I'm particularly keen to take advantage of the potential connection between I guess health inequalities, employment, and that plan, which seems to address some of the workforce needs of the NHS over the next 10 to 15 years. A big focus at the moment is on winter planning, as you might expect, and obviously David, our Chief Medical Officer, along with Richard Jenkins, one of our other system chief executives, have been doing a lot of work with place partners around preparation for winter. I think we're in good order, but it's always a challenging time, and obviously critical to that will be the vaccination programme. And I mean, Anthony, I don't know if you want to just give a quick headline in terms of vaccination.
Yeah, members will have seen in the news last week that we're bringing forward the COVID and flu vaccination programmes based on a variant of concern that's been discovered. And we're going to start the vaccination programme next week for our most vulnerable residents. That are those in care homes, and we're got a planning workshop this afternoon actually to finalise our approach with that. Vaccinations in South Yorkshire will be undertaken by a combination of GP practices, primary care networks in our communities, and various hospital hubs across our towns and cities. There will again be a focus on getting into those hard to reach communities, underserved communities, to make sure that we get people protected. And there'll also be a focus on our frontline health and social care staff to make sure it's a big part of our winter planning. There will be a focus on co-administration of flu and COVID-19 vaccine where it's appropriate to do so. We know that's not always the wishes of our residents or indeed our staff, but we'll make sure we tailor our model appropriate for the best use of our resources. As ever, we will have some big national, regional, and ICB-led communications as part of this programme. And I encourage board members, as ever, to share those, to promote those, and we get as many people across across South Yorkshire vaccinated coming into them.
Thanks, that's been really helpful. The final thing I just wanted to draw out of my report was probably more closer to home, and it relates to the ICB itself. So one of the challenges we received from NHS England earlier in the year, and to be frank, it was anticipated, as you bring organisations together. The ICB was formed from 4 former organisations. You might expect that economies could and should be made. So we were set a challenge by NHS England to reduce our running costs by 30% by the beginning of 25-26. In a sense, in 2 phases: 20% in the coming financial year and 10% in the following year. What we've chosen to do is to respond to that in a single step, really, mostly because clearly most of our resources are related to people. And what we didn't want to do is to have a protracted period of organisational change. We wanted to be able to give people certainty about their future as soon as possible. Just to position that, we employ about 800 people within the ICB. About half of those colleagues are involved in patient-facing and clinically related services for programme costs. They're not affected by the 30% reduction. It's more those colleagues involved in planning, commissioning, those sorts of activities. So we've been working with obviously our own people, with our trades unions and partners on a process of organisational design over the last few months to work out what the new form of the organisation will look like. And as a result of that work, we're now able to give some certainty to colleagues about which roles are affected as part of the organisational change that will be necessary to meet that challenge. So we've got a consultation document that we've developed with our trades unions, and that will be considered in a private session of this board after this meeting, which is unusual for us. I mean, generally speaking, we don't have a private session of the board. Our business is transacted in public, but I'm sure the public will understand that this document relates to specific individuals and their employment, and it's only appropriate that individuals find out about that directly from us first. So we'll have that conversation in private this afternoon, and if approved, we'll then commence a consultation formally with staff and trades unions to enact the necessary change. I think the final thing I'd want to say is, although it is a change in how we organise ourselves, it does not diminish our commitment to working in place with our partners in place. It does not diminish our commitment to working with our collaborators and alliances. And if anything, in terms of our aims as an organisation, the strategy we've developed through the Integrated Care Partnership, the ambitions that are set out in the Joint Forward Plan, our intention is to put ourselves in a position where we're better able to deliver our responsibilities to those plans as a result of this change. So clearly it's an incomplete picture that I'm presenting, Piers, but for obvious reasons.
Okay, thank you. Leslie, do you want to say something? Yeah.
Just reflecting back on the industrial action, obviously our key concerns are patients and the impact on them. But we did raise the People, Workforce and Culture Committee, and we just wanted to express really our thanks to our staff that have continued to support during what's been a really difficult and continues to be a really difficult period, putting them under extra pressure really around a time when they're also looking at other things like running cost allowance and the day-to-day business that continues. So we just wanted to really minute our thanks to people and acknowledge the extra effort and commitment people have shown.
Well said, thank you very much. Kevin and then Moira. Kevin.
Yeah, thanks, Chair. Can I just pose a question to Gavin around specialised commissioning?
Yes.
I know within your report the emerging risks associated with delegation of some of the specialised services from the 1st of April, particularly around the uncertainty of capacity and capability from the public. At what point will the board be able to judge the extent of those risks and our decision or not to accept delegation, if indeed we have a right to not accept delegation?
Thanks, Kevin. It's a really good question. So really, the reference in my update was, I suppose, a sort of a placeholder, and I think we will clearly want to bring because that delegation is a transfer of undertakings. There's a sender and a receiver, and I think what you're describing is our responsibility as a receiver to assure ourselves to do due diligence that this is something that we're kind of well placed to take on. So we will be bringing this back formally to the board for approval. I suspect it will also go through our governance processes before it comes to the board. So, I mean, I kind of Emma and Lee, I mean, obviously you're particularly active in this space, but I don't know if there's anything you want to add to
We're
that.
doing the PDAP at the moment, and that's really to summer in September. We will bring something back to the board probably November, December in terms of what the risks are, but we are working on it. We have escalated all of those and we'll say more, but we have escalated all these things into anything, so it won't be surprised, because, you know, when the actual final document comes out, because we have continued to escalate the risk around capacity capability and the financial risk associated with this too.
These were over.
So there are a number of risks in this arena, but the one we're currently grappling with most perhaps is we understand from NHS England that the proper proposition is there'll be a transfer of responsibility for these services on the coming 1st of April, but there's unlikely to be a staffing transfer associated with that, with those staff arriving to discharge those responsibilities because of the NHS England reorganisation and the timing that it will take to get to that process. So we're kind of currently reviewing, well, how would we potentially take the responsibility for these services, but without the staff to do it, and how would that mechanism work? So we're firmly into that conversation. I mean, this is an agenda we're really keen on exploring about the connectedness between these services and the services that were previously commissioned by the CCG. So I don't want to describe this as an entirely risk-laden venture. It's not without risk, but there are opportunities there about bringing together the commissioning of end-stage renal failure with acute kidney injury, and can we do something in that space? So there are opportunities there as well. So, but we need to be getting into that space with open eyes. So I think in a couple of months, Kevin, we're going through a sort of formal process of pre-delegation assurance work, this PDAF thing. But I think there's a broader conversation to be had about the risks and opportunities of this delegation and how we might face into those well and better.
Thank you.
Moira, did you have your hand up?
Yes, I think
And then-
just very quickly in relation to the statutory independent inquiry, which of course obviously everybody welcomes. I just want to make a point about the relationship with the 4 safeguarding boards within each place and their oversight in relation to assuring safeguarding in a place. So I know every organisation of health and social care will have its own arrangements in relation to Cream, Speak Up, Whistleblowing or whatever. But I think it's important for us as a board to make that link back into the 4 place safeguarding boards, children's and adults. And I know I am an independent chair of one of the safeguarding boards, so Kathy and I have got a conversation next week about how we can strengthen that at South Yorkshire.
Yeah, one of the interesting things, I agree, we've only read stuff through the press, is at no point did I read about the links to safeguarding, whether they looked at it, which felt to me like a bit of a gap. Richard.
Yeah, a couple of points really. One on the Council Chester issue, which is that clearly, I think Gavin touched on this. At this moment in time, we know what we know, which is mainly what the press could have been. Clearly, that's been about a limited focus. And I think it's really important that we do get as much information as we can from the provider otherwise, so that we're actually looking at all of the right things. Certainly, from what I know, I think there are wider implications than just the freedom to speak of regulators and NHS managers, because I think it's quite a lot of details on absolutely my colleagues involved in that. So I think it's really important to get that right. Second is just to register that I do think it's fair to say that the SDH manager children's hospital are particularly worried about the specialist commission issue. And I know that they are involved in the discussion, but I think they will be really, really clear on how it will work and actually demonstrate the benefits, because they are very, very concerned about the potential implications for them with their activity there in this associated.
Absolutely understand that. No, inevitably they will, and we need to actually look after their interests. This is money we want into South Yorkshire to make sure it works. Okay. Thank you. Anything else?
That's it. Thanks.
Gavin, thank you. We then have questions from the public. Andy, you're going to read them out and there's some answers as well, am I right?
I will do indeed, yeah. So we've got 4 questions from the public. The first is from Samantha Jones, who's Associate Director from the North Eastern Yorkshire Stroke Association.
Okay.
Samantha asks, given that stroke is a leading cause of death and disability, and with stroke survivors leaving hospital with an average of 7 disabilities, many needing complex and lifelong care and contributing to delays in discharge and pressures across the system. But the stroke delivery network is an essential part of the system, and what plans are in place for funding that in the future. And I think our answer is very much that we recognise that stroke and cardiovascular disease are leading causes of death and disability within the region. we're very fortunate to have a well-established integrated stroke delivery network in South Yorkshire, and we've had that for very many years. The current funding for the programme and staff comes through a variety of sources, including NHS England, the ICB, and additional funding opportunities. So we are endeavouring to provide the best care possible for our population through that service, and I think we're fully committed to it. I think and a full response will be posted on our website and sent to Samantha about that.
So let me just repeat that. So
Yeah.
we'll answer briefly today, but any question will also, the full response will go on our website. That would be our normal way. Sorry, Andy.
Yes, and sent to the person asking the question directly as well.
Thank you.
The second question is from Catherine Oldham, and I think Catherine joins us online today. So Catherine's question is that the South Yorkshire ICB 5-year joint forward plan was published in June 2023, and it states that the NHS will be redesigning services for learning disabilities and autism, specifically in regards to the suicide rate associated with these conditions. And Catherine says, as will undoubtedly be aware, many individuals with ADHD suffer from suicidal thoughts and ideation, which can often be mitigated with medications. Catherine asks, given that NHS waiting times for these individuals to access treatment and diagnosis can save lives can be lengthy, what guarantees can we give to them? So we have got a full detailed answer to this, which we will send to Catherine and post on our website. But in essence, we recognise that demand for autism and ADHD assessment has risen exponentially over the last 20 years. Investment in those services has not quite kept pace with growth. So we do recognise that. And we kind of identify the areas of data and digital, pre-assessment support, information education, and assessment pathways, and the triage and diagnosis, all as areas that need further support. So we'll send details to Catherine about what we're doing on those important measures.
Thank you.
The third question is from Jim Richardson, and I think again Jim joins us online. Jim pulled out from the Chief Executive's report that significant funding to be allocated to improve primary care telephony services, and I think Gavin mentioned that there were 42 practices that would be receiving together more than £1 million. Jim asked what the timescale for this work is, supplier identification, and who can be contacted about that. We'll provide those to Jim. And secondly, Jim asked about NHS England's priorities and operational guidance. And again, how are we working together? Are NHS trusts working together on that? And who would be the best person for him to link to? And again, we'll provide those contact details to Jim. And very finally, a question from Haroon Rashid. And Haroon contacts us about deaths at Sheffield Children's Hospital. Haroon's actually written also directly to Kathy Winfield as Chief Nursing Officer. So that it's proposed that Kathy contacts Haroon directly. Is that right, Kathy?
Yes, I've received a letter from Ms. Rashid this morning. So what I would propose is that I contact him to get into a little bit more detail, because there are a number of concerns that is expressed both through his question but also through the letter that we just need to get underneath, and then we can give a response for the website, but also directly.
And we would not deal with individual cases here.
Yeah, and I think Gavin and Richard have covered off quite eloquently the kind of work in progress around where organisations may flag and the work that we do and the governance processes that sit around.
That's all, Chair.
Thank you very much, Andy. Thank you. And as we said, those replies will both go on our website and full reply directly to the individuals concerned. Okay, place reports. Barnsley. Now you're first because of alphabetical order, not because you won county. Wendy.
Yeah, I'm naughty, aren't I? Honestly. Yeah, thank you, Chair. Just a few things just to highlight from the wonderful place that is Barnsley. Is that we have seen our Children and Young People plan launched very recently, which really aligns very nicely to both the 2030 strategic priorities for Barnsley across our health and care plan. And interestingly enough, we've agreed to do some work together amongst our strategic leads for Children and People's Plan, a number of other plans as well, to answer the question about how do we create simplicity where complexity exists with regards to the number of improvement imperatives, and people are getting a bit lost amongst them all. So we said we'll do a bit of work and linking very well with Marianne as well, I think, to help us with that work. Really pleased that on our Creativity and Wellbeing Week, again, which is supported by our Wellbeing Alliance, Creativity and Wellbeing Alliance, that we had a particular focus on people with a learning difficulty and a learning disability who can experience particular barriers to accessing all that the arts certainly and the creative sector can bring. So it was great to have a targeted conversation with people that work in that sector, of course, people with a disability and for themselves. Great that we're kicking off, as many places are, the launch of our family hub efforts, and again thinking about how those designing those family hubs link and connect with our neighbourhood, integrated neighbourhood offers. Our hospital's really chuffed, as the saying bars, really chuffed to receive the 2.4 million of investment that will help them to create the additional 56 beds. It is really a tight footprint across parts of the hospital, so clearly this will really help them to get that additional capacity and manage some of the surge incidences that we sometimes have. And a couple of other just things to point out. We welcome Anna Hartley, who's joining us soon, and David and I'll be connecting with Anna soon as our new Director of Public Health. She'll be commencing in September, starting with September, so that'll be a great addition to our extended leadership team. And finally, probably the only other thing to highlight is that, a couple of other things really, is that just a bit of focus on domestic abuse for older people. We often feel that's a hidden conversation. People don't talk much about that. But we know with loneliness and with all sorts of issues that affect people in our older life, in our older years, really, that it can be a challenge for people. So, but a great event that brought a number of people together from both the community sector, from our Safe Glasgow Park, and all other individuals really, and it was led by Age UK, and it was great that we were able to really understand how that works in Barnsley, what we're proud of, what we're challenged by, and what can we do. So getting under the skin of that was really important for us. And then finally from me, Chair, is when we think about discharge and flow in Barnsley, one of our pressure points we know is intermediate care. I think we'd all felt that it was sort of all right, but actually when we lifted the lid on the engine and lifted the bonnet and had a good look at the engine, we realised that perhaps it wasn't all as good as we thought it was. So we've been working together with an improvement partner to understand the model of intermediate care, and we were sort of adding that to our place partnership that we worked late this week about how do we tackle some of the challenges around the bed base in there, but actually what's the model we want to try and achieve, which is clearly more of home first principle, 80% home first, 20% bed based, and how we're going to achieve that together, how we're going to tackle the capital requirements that will bring. So creative considerations for that. I'll leave it there. Thank you, Chair.
Thanks. Any questions for me? Anthony Doncaster.
Thank you, Chair. This month I've tried to concentrate upon our integration of work and approach that's highlighted a number of success stories across our city, and this sets the template for the work that we want to do as partners in delivering our place plan. As you'll see from the report, we're refreshing our health and wellbeing strategy. It's intrinsically linked to our Fairness and Wellbeing Commission that's chaired by Dame Rosie Winterton. We had a report of the halfway point of that at our Health and Wellbeing Board last week. Some very interesting findings, but now it's about publication recommendations in November, and that will set the template for our health and wellbeing refresh. Highlighted in the report is our one approach to engagement and co-production at place. We've got good progress on that and getting people, our organisations coming together on how we engage with our communities, based on feedback from our residents about stop coming and asking us, come together and ask us, quite frankly, Leslie. So there's some good work coming out of there. All of this is based in our ongoing commitment to health inequalities in Doncaster, and you'll see signed up there is all our chief executives against organisation. That gives a flavour of our commitment in there. So some good progress in that area. Couple of pilots that we're particularly interested and proud of. We've done some link of our primary care networks and our Citizens Advice Bureau in Doncaster, and taking advisors into practices to have that footfall of people who we really feel could benefit from advice. The the evaluation of that programme is really good, and we had a presentation at our place committee a couple of weeks ago, which showed the sheer volume of unclaimed benefits that our residents and are not claiming, and by being patients there, they're getting the right advice and being signalled to the right areas, and we're helping them there and then, which I think is a great pilot and can be rolled out, I think, across a number of our PCNs and practices across South Yorkshire. Also, the work that we're doing around mental health navigators in collaboration with St Ledger Homes in Doncaster, and they've taken a number of referrals from irrespective of the source and signposting our residents and our vulnerable people to the right areas. And again, that evaluation is really good. We've been nominated for a number of awards, which I put in there, but there's just a couple that I put in there because they point very much to the integration approach across partner organisations, but across professionals as well. And our Wound Care Alliance has been shortlisted for an HSA Innovation Award. Again, multidisciplinary working across organisations, putting the patient at the centre of the work that we do. And also our Mental Health Crisis Alliance, which again, I'm particularly proud involves people from our voluntary community and PAVE sector coming together to help people in that area. Finally, if I could, I just wanted to mention a couple of things that aren't in the report. Damien's on the line, but would like me to mention that Doncaster was announced a couple of weeks ago. We'll be getting a second university technical college into our city. Just to remind people, they're government-funded educational providers, but have strong links with the business communities, and are able to set their syllabus and their links very based on employment. We've already got one in Doncaster that's based around the industry sector, but this second one will be very much around health and social care, and I think that's exactly the sort of links that we want to make. It's due to open in September 2025, so we're really excited. We've had some disappointment in Doncaster around announcements really recently. This is a great one for us. And then finally, if I can, and Gavin and Richard may want to come in on this. Since our last board meeting, we've had the ministerial visit to the Doncaster Royal Infirmary site. I think it was a good successful visit. Richard was able to take Lord Markham and a number of our elected representatives around the DRI site. Broadly, it's on the forward plan for this board, but broadly we're in the situation of three main work streams. The first is the immediate work that needs to be done around identifying capital priorities to make the current DRI site as safe as possible for our patients who are in there, and there's active conversations going on at the moment. The second piece of work is how we're coming together as partners to look at decanting appropriate services away from the DRI side into the community, outpatients, walk-in diagnostics. We're keen to learn from the Barnsley Glassworks programme, and we're going to come together and put some pace behind that work. And then the third one is what might be described as maybe a Plan B proposal for a redevelopment of a new hospital site based on those two pieces of work. I'll pause on that in case Richard wanted to add anything, or Lee or Gavin, to that last point.
I suppose in the current climate, it's really important to stress that the issues at DRI are not related to radiated, aerated or circulated.
I know that.
Yeah. Because I think it would be easy at the moment to assume that they are. They're related to the general age of the site and the amount of additional capital it takes to keep the site in the appropriate order for the patients and communities we serve, and that's related to what's called the heritage stage return based on what sites we need to do. DRI is a very, very busy site. I think it's the second busiest site in South Yorkshire, cases for patients a year, and clearly it's developed over time with different building structures. And some of those are in need of much more maintenance than actually current capital allows to take each year. So that first piece of work really is just about trying to secure additional capital to increase the maintenance budgets whilst we determine whether we can see capital for more major bills. I think that second part is about, and that Anthony mentioned about looking for alternatives to DRI, is that we are seeing across the country some really innovative ways of delivering patient services closer to home, you know, and also close to facilities that patients use every single day as part of their normal working lives. And I think the Glassworks is an example of that, where providing the facilities in a place where the community can easily access has increased attendance rates for things like screening. It's also reduced DNAs because patients find it much easier to travel. So I think what we're going to look for in Doncaster is those sorts of services where we provide them locally, but we provide them to a higher quality than we're currently able to provide in the DRI buildings, with the aim of improving the patient's experiences and also the experience of our colleagues. Our colleagues getting to DRI suffer the same sorts of challenges with access to the site, parking, you know, the sorts of pressures that really do affect patients' experience, that's experience. What that will then leave, we hope, is a clearer opportunity for us to be absolutely certain on what type of refurbishment or rebuild work we need in Doncaster to provide modern day acute health services that only hospitals can provide, which I think is a very different definition than perhaps it was in 1948 when NHS started. And I think that's what we are seeking to try to do in Doncaster on the back of what was quite a disappointing decision for us, but with every disappointment brings lots of opportunities, and I think this is an opportunity to think differently. And I think that's the opportunity that we're going to try and take.
That's really hard. Thank you. Rotherham, Chris.
Yes, welcome to Rotherham, everybody. No awards this year, this month, I'm afraid. So what I'm trying to do in the report this time, I'm trying to give the board members a flavour of the business that's going through the Rotherham Health and Care Place Board. So I picked out things that are relevant and up to date. The first thing we looked at the last meeting was the long health check programme. This is something we've been running for quite a while now in Rotherham, but it's just coming, we've started to get the findings out now, and we started to see we've had 4,500 long health checks undertaken, and 259 follow-ups have been had, of which 21 cancers have been found. So these are real examples about how we're changing people's lives. I mean, genuinely improving health outcomes. It's been a complete success. I know we've had it in Doncaster start, it's going to be Rotherham, it's going to be rolled out in other places, but it's just a whole thing that has just worked brilliantly. So being that proactive, preemptive approach that we all want to do is just a real good example. The other one is the Rotherham Town Centre regeneration. Now, there are some Rotherham colleagues around the table. This has been in the offing for quite a while. This is happening. I mean, I was down on the site a week or two ago. It's being built now. You know, it's a significant development in terms of Rotherham. In terms of the economic regeneration of Rotherham, it's important. I mean, we've got a big role to play as an ICB. So the sort of things I'm doing as ICB Place Director, we've currently got ophthalmology outpatients living in the town centre, looking at further specialties being delivered. We've got looking at mental health services, so dementia not-dependent cap is in the market, redevelopment, potentially mental health outpatient services in the town centre, looking at putting GP extended access in the town centre, near the bus station, the train station, easy to access for Rotherham people. There's a real big thing for all the partners to play, but this is going to make a huge difference. Central Promise, it is a big thing that's been coming for years. It's a bit on the back of what happened in Barnsley. It's sort of that sort of scale of the investment that's going in. So that should all be up and running for March, April next year. This isn't something that's on a big time horizon. So the challenge for me is to get as many services and as much footfall into the town centre as possible as we move forward. There's a few examples now on medicines optimisation. This is something obviously we really tried to do a lot of transformation work on medicines optimisation. I think in Rotherham, just GP prescriptions in Rotherham is £60 million a year. You know, it's a huge amount of resource that we put into this. So we look to redesign wherever possible. And we tend to pick areas where we're most challenged. So the areas we've picked, I just picked to a date on the diabetes management, where we've seen an increase in 14% of diabetics in Rotherham over the last 3 years. We picked infant feeding and also antidepressant reviews have been the areas where we've picked and seen some traction and success already, and they're highlighted in the paper. Just the last one. So the winter plan came through our board. The big change in Rotherham for the winter plan this year is our virtual ward approach. So the paper details what a virtual ward is, but it's basically wrapping services around patients in their own home to stop them need hospital services. Our ambition is to get to 100 virtual beds by winter. We started in December, January this year from the starting point of 0. Just last week, we're now up to 40. We're seeing frailty, we're seeing respiratory patients, and are moving to heart failure patients as well into the virtual ward. And we're on trajectory to get to our 100 per winter. So seeing great success there. And obviously, that's something we're keen to learn off the other places. We all develop our models. Obviously we'll share our model, but I know we're all developing in slightly different ways, which I think is a positive thing. Because some things will work, some things won't work so well. So it's just about learning together. So that's something as a place directors I know we're keen to do. But the Urgent Care Alliance particularly is the key owner of this piece of work. So that's the model update.
Thanks, Chris. Can I
just to note, it's kind of something and nothing in the grand scheme of things, but it's probably of marginal importance in my perspective. I went to last Rotherham Place Board, and an action that fell out of that was I'm hosting a session for the Rotherham Council Section 151 officer, the place finance lead, and the 2 hosted NHS organisation leads with SIPFA and my opposite number from Greater Manchester, where we were exploring some of the financial structure barriers to partnering well with local government, which I think is really important. The finance regime for local government is so desperately different to the NHS regime. There's some very specific work we need to do to kind of bring together prevention, public health, the way we deal differently with adult social care. So that session, if it goes well, could be available in the other 3 places. I didn't want to spend time solely in Rotherham, but I think it's really important we get under the bonnet, to carry on Wendy's metaphor, of how do we partner better with local government colleagues, because the finance regimes can be so jarring and different. So we'll start in Rotherham. If that goes well, I'll get some Greater Manchester and SIPFA colleagues along to that, because I think I would think it would not, but I think that's quite an important piece of work.
That's really important. We have Leslie.
Yeah, thank you, Chair. Can I just go back to Anthony? Sorry.
That's about 3 ones ago, Leslie, but go on.
Anyway, so I just wanted to really acknowledge that work around benefits and how important that is in terms of health inequalities and people's general quality of life. And so are you anticipating that work will continue? And is the potential for it to widen out, Anthony? I'm just thinking that there will be other specialist advice agencies in Doncaster, as there are in the other places, that could add to that party. And it is really important. We're upping people's income, but we're also understanding those other things, particularly around debt, or inability to heat your home, or whatever it is that affect people's long-term health conditions as well.
Every intention to roll this out, as ever, it's money to get this going, but we've been able to do that in Doncaster with some non-recurrent monies in our relationship that we've got. But the evaluation, Leslie, is fascinating, not only on the amount of unclaimed benefits from our residents and their satisfaction after this fortuitous conversation that they're having with somebody else set it up, but also on some of the savings on the public sector in terms of the fact that we've got them there rather than accessing services that might not necessarily need to do so. So in answer to your question, that is very much the ambition, and we're going to steer that through our primary care alliance that we've got set up to see how we can roll this out to, first of all, other places in Doncaster, but other places around South Yorkshire if there's the appetite for it.
I suppose in other things repeated through social.
That's right, yeah.
But that direct relationship between a GP practice, because they're not where else to go, really, because they're so stressed about all of that stuff, and how we can break that cycle. Can I just ask Chris, it's really more of a comment. I was really interested in that whole thing around medicalisation, and again, I think yes, okay, that is about the impact on expenditure to do with medication, but actually you can see improvements in people's lives there as well.
Absolutely.
If people are not taking antidepressants, they don't need, because you've managed to deal with that in a different way, or if people are managing their diabetes. But I just think again that getting further back downstream stuff is really important in all of this. It's not just about the money.
Absolutely.
Kevin.
Thank you, Chair. Just like to comment about the really impressive ambition around virtual beds, virtual ward within Rotherham. And maybe for a future meeting, it would be helpful, maybe within the place reports, to understand the art of the possible in other places as well, and what we can learn from that, being as such a fundamental part of our winter planning going forward.
Chris, thank you very much. Emma, Sheffield, please.
Definitely no more from Sheffield, sorry, this morning. But I think probably just starting with the money actually. So just picking up your point, Lee, I think from a Sheffield perspective, we had a session back in May. We started to look at efficiency. So actually we have all of our sectional plan officers, we have the chief finance officers from all the partner organisations starting to share information on what we spent to assist against our 5 priorities, which was actually really refreshing, because I think, you know, when we move forward, we've got to be looking at the total resource that we have in place and how we use that differently. We've got a second session on the 22nd of September, just again start pushing out what does it mean. Actually, we can't do things around the edges, we can't think around the edges. This is fundamental. Talk about left shift, what does that actually mean and how we actually do that. So doing quite a lot of work on the money. I haven't got all the answers yet, but we're on it. I'm trying not to look at you two. In terms of a place update, obviously we've given a brief update on 3 of our priorities. So mental health, you'll see there what we're trying to achieve. Some of the stuff we've put in place around safe space, the Sheffield Support Hub. We're really at the start of this. I think there's a lot of work to do around crisis, particularly for people who continue to be in crisis, who attend RED, and actually we're not sort of following up and supporting them in the right way. So we're doing an awful lot of work in this space at the moment. Moving on to neurodiversity, we've talked about that. I think all this work will fall under the Sheffield Autism Partnership. So we are not just looking at children, but adults, and that transition period is really key here. So we are actually looking at, as a city, how do we become really sort of autism friendly in terms of employment as well. And we talk about dementia friendly cities, but actually how do we become an autism friendly city and actually mean that and really get people into work. So we're doing a lot of targeted work specifically on the children and people's waiting list. But again, this isn't about a medical model. It's still very medical, but actually this is a social model. It's about how we work with schools and our partners in a very different way. And it's a long-standing problem and not one that's actually local to Sheffield. It's a national problem. So doing a lot of work on that. In terms of the model neighbourhood stuff, we've now identified our 4 sort of areas, which are Burnbreed and Grimsthorpe, Crabtree and Third Vale, Third Park and South Green East. And they're the 4 areas we'll be absolutely focusing on in terms of building our model neighbourhood. And this is very much around power shifting. It's about saying we don't have the answers, what are the solutions? We've got ring-fence resource around that. We've also got some match funding from Sheffield City Council, so we could do some really good work in this space. And we've developed a draft set of principles, and we're working with Voluntary Action Sheffield really to help us do this. So it's not about big organisations telling communities what they can and can't have. It's actually about really empowering and transferring power into those areas. And we're particularly looking at balancing and funding for black, minority and ethnic communities, because again, we haven't seen that, and we really need to do something about that as part of the work we're doing. So some good examples going on. I think the last thing I really like to say was just around the STEM report. So again, you'll see we have had a good news story, not on the wall, but actually moving us in the right direction in terms of how we work. Really interesting to see that, you know, the comment made about the multi-agency ways of working and the new interrelated structures have achieved a culture change. I think that's really important. Often we tick boxes, we talk about process, but this is about being different, about creating a culture where it's everybody's responsibility and accountability. I think that's the way we're trying to work in Sheffield now in a very different way. So that's all I wanted to say. I'm guessing people are ready, but happy to take any questions as ever. Thank you.
Thank you. Any questions from it? That was really, really helpful. Thank you. We move now on to what I would describe as, whenever Lee speaks, as the depressing bit of the business, which is the financial plan. Lee.
Thank you for that, Billy Pierce. That's really kind. So there's a statement here, a restatement, I think, about the plan composition. Hopefully people are slightly bored of me now saying what the component parts of the financial plan. We added up to the incumbent cost of the system to have the 23-24 plan. We then added in all the national house and local investment standard, further elective recovery work and other items that were nationally mandated. And we finished up with quite a stretching financial plan is what we previously reported. So there's an expectation that each of the hosted NHS providers deliver a 4% efficiency. busily delivering. I look at Richard at this moment, with a nod, take some affirmative action, so they're busy
I
delivering
think that constitutes a nod, Richard.
Constitutes a nod. There's a 1.8% efficiency requirement in each of the 4 places. I'm describing that as allocative efficiency. How do we do things differently around here? And then in addition to that, we need to find a further 110 million. We have sort of outline plans for that in terms of delivering financial balance, but there's a lot more work to do in that space in terms of delivering financial balance in the year. It is a very risky plan, as we discussed in the Finance Committee last Thursday, and we will discuss again on the 2nd of October. In terms of the month 4 position, we have a total deficit for the ICB and the hosted NHS providers of £29 million at the end of month 4, 30 million if you do the rounding properly. We're now doing loads of work about what does this mean in terms of forecasting and the risks in that plan. So what's going on in community healthcare costs, what's going on in primary care prescribing, what precisely is happening in terms of the cost-based change elsewhere in the system. So this report describes all those additional pieces of work we are doing. It also then goes on to describe the work we're doing at NHS England's behest about financial recovery and medium-term financial planning. Very commendably, I think we're starting earlier this year to look at the sort of more medium-term financial prognosis of the system. So that work is initiated out of the ICB, but it's wrapping in partners, and I think that will enable a sort of longer multi-year view of how we're going to deliver financial recovery over a longer period than 1 year. The bit of the conversation that I'm getting really interested in perhaps is just how we think very differently about delivering efficiency, and it builds on Emma's point really. The size of the financial challenge, if you look at our benchmark improvement headroom, if we were at upper decile of doing everything we currently do well, we wouldn't make enough savings to keep delivering the services. So we're talking now about doing different things, not just doing things differently. We're talking about doing very different things. And there's a slide in there which talks about efficiency planning. There's quite a lot of work going on in the ICB about capability building around improvement science and CUSA training. I mentioned that because it's not peripheral to this. It needs to be centre stage to delivering sustainable improvement. There's lots of work then about trying to describe the accountabilities that they sit in the new system we have without a purchase provider split, about organisations delivering technical efficiency, us as an ICB helping around allocative efficiency and delivering that. But I think particularly we need to have a conversation which is starting to be teed up about the federations and alliances thinking differently about disposition of services and how we deliver across provision. So we're getting into that conversation. We need to think about just this overall enablers for efficiency work around, that we really understand what the opportunities are, and we've got to get a lot better at our programme management about the inputs into efficiency delivery. I'm quite good at recording, have we done it or not, in the year-to-date financial performance. What I'm not so good at is going, there are these actions that we have taken which have enabled us to change the services we're delivering. So there's a lot of work going on about building our programme management infrastructure linked to CUSA to enable us to do that work better. I think we're going to need quite a radically different view of how do we look at segments of our population cohorts differently, and understand how they are accessing services in a way that's neither clinically nor cost effective. Because we've had an episodic care model for a long period of time, we need to think very differently about how we reach out into different parts of our community. So there's just sort of think piece there, largely from me, about how we do this, and a reference back to the joint forward plan which mentions this. On the cover sheet, there's just the sort of comments on this from the exec team when it sort of had its first outing around how do we link it together with workforce better, all of this work, which is really important. This accountability for delivery at place, we've got to run to ground. So I think we're socialising how do we do this better beyond the finance community, because it's everybody's business. The FIC conversation that we had on Thursday was a bit around, can we just have some real clarity on the 2nd of October around that 4% or 1.8% for 40 million and where we go on that? What might it take to sort of close the financial gap in terms of that extra 69? Can we have a very specific update on how we're doing on temporary staff and spend? There's this view of sort of top-down views of efficiency versus bottom-up, and how do we get into that space? And I think the really useful conversation in Finance Investment Committee, and also all the useful conversations, obviously, was about a really clear statement about what this transformation agenda needs from a different sector perspective. How would the BCSE sector engage in this well? How would primary care, local government colleagues engage in this well? And what would it take to engage in this transformative agenda in a different way? So there's loads going on, but just to reiterate, it's an incredibly challenging financial position. We will have a focus meeting with our NHS England colleagues tomorrow morning. I imagine much of their focus may be on money, so we look forward to that. And we'll carry on this conversation in System Leadership Executive next week about how do we mobilise around trying to improve in-year financial delivery further, and what does that framework look like for efficiency and transformation in the context of multi-year planning and 24-25. I've probably said enough, Piers, so I'll shut up.
Really helpful, Richard.
Yeah, thanks, Piers. I would nod. I think we all really are trying very, very hard to deliver the financial plans we've signed up to. Clearly, there's some issues in there that we weren't expecting. There's still issues, and we've touched on those already. The industrial action is having a significant impact on our ability to deliver our financial plans and also deliver our activity and performance plans. It's all of the impact of having to rework all of the patients' visits and treatment plans on the days of the industrial action. And I think we're all really worried that if this continues into the autumn and winter period, then the impact will be much more significant. Particularly as everybody in this room will remember that the vast majority of our financial plans are backloaded. Yep. They are loaded towards maximising the sort of benefits and the opportunities that we saw towards the autumn and winter months. And some of that was, as Lee indicated, around the costs in previous years of providing temporary workforce solutions. And actually, in most organisations, the acute sector, those were some of our greatest costs in the last 2 years have gone into those sort of solutions. So, I think we do need to know the risks increase, and by nature, the longer that the strike action goes unresolved. I think the second point would be absolute support to some of these comments about at a personal level. I really do think we've got to think differently about the way in which we do provide services to our public. Better meets their needs now in today's society as they see it, and so that we can get back to addressing some of those quality and efficiency benefits that are there, I think, in a world that is becoming more digital for those who are able to use it, but also supports the communities and patients that can't in a much, much more way that's met to their needs and where they actually live and want to receive care. And I'd encourage that we push on that as hard as because that's what's going to impact make a huge difference. And I support the Q2 approach because I think people who know and do the job are probably the best able to self-design how it should be done.
Moira.
Yes, thanks, Chair. Just on behalf of the Finance Committee, I mean, we had a really useful discussion last week, and I mean, I know Lee and colleagues and indeed everybody across the board is working really hard in what is a very difficult financial challenging situation. I think from an assurance point of view, I think the committee and the board will be looking for a bit more detailed information about how assured we can be about the delivery of the financial plan and bridging that gap within the financial year. And I think, from a non-exec point of view, having a bit more specific detail of exactly what everybody is trying to do to bring spend in line with budget, given the difficulties of that, how we can actually support that.
Yeah, it's just, I guess one of the points that Richard made, but also in terms of kind of bringing different sector views into that whole finance conversation. I just wanted to throw in the mix there that when we're talking about kind of wider engagement with the BCF sector, just recently speaking to a number of colleagues within the kind of health and social care element of the BCF sector, one of the current issues that they're having is trying to compete in terms of recruitment, because they can't match the pay scales that we have in the NHS or they have in other parts of the public sector. So it's actually, we are doing a bit of thought leadership work around that. But the reason I raised that is that if we're then talking about commissioning, if we're then talking about financing and resourcing in a different way, we're then talking about providing services in communities in a different way, there has to be something in that mix about, well, actually, what's the levels of You know, are we matching the level of pay with our wider one workforce strategy within colleagues within the VCF? So I think there's an emerging conversation to be had there, but I just kind of want to throw that in the mix because we're at risk of not being cited on that, especially if we're then relying on those VCF colleagues to pass for us.
Absolutely, she really, really well made point. Will, you just come in.
Thanks. Yeah, just a couple of things. And it just relates to the Arsenal joint plan, just in terms of some of the more formal feedback we've received on the full plan. So I'm really thoughtful of the conversation we had at our joint health overview and scrutiny committee a couple of weeks ago. And we were commended on the vision, the ambition and the priorities that were in the plan, but there were some questions around delivery, particularly in relation to the financial climate. And I think that was most clearly seen around our commitment to be prevention first, getting on wider determinants and focus on health inequality, but concerns about having to do some of that all at the same time as trying to recover services. Because in the previous week at our Interest Care Partnership in public session, I think we were hearing hospital leaders telling us, for example, that what we know is services aren't perhaps the way they should be in terms of quality, and we know that, don't we, from that public holders. So there are so many competing agendas. So I just wanted to highlight that here rather than in the paper. But I think my second point, which is my main point, is, and I think, Lee, this is what you're saying, I think there's something for me around clarity of our vision and ambition around transformation. And there's lots of it, and we're hearing, aren't we, all the great transformational work that's happening, our organisations and that place then across Yorkshire. But I just wonder if what you're saying, Lee, is actually being crystal clear about some of those bigger transformations that would be good for our population. Actually, they'll enable us to get to the health inequalities piece. But actually also they might really help us with some of the challenge. I know you describe it, Lee, in our joint forward plan and in your report as demand failure, but I think what you're describing is how do we fast track doing the right thing for our population, which ultimately will be the right thing for our services that are trying desperately to do a fantastic job in a difficult. It's that transformation thing that I think we need to probably think a bit differently about, or bring forward some of those bigger, bolder ambitions.
Kevin and then Lee.
Thanks, Chair. I think clearly we have to have a focus on doing the very best we can in this financial year, and Lee's already rehearsed the next steps for that. I welcome that, but I also welcome the work on the medium-term financial plan leading to a financial strategy, because again, building on Will's and Lee's point, we've got to move very quickly along the scale from tactical changes to truly transformational. And so I'm really hoping, and I think you did say this, Lee, that in terms of developing a financial strategy sooner rather than later for the longer term, to develop with all of our partners across the system. But I do think that we do need to be very clear about investing in transformation. At the moment, in some areas, we do transformation on the side. And by investment, I don't necessarily always mean money, but in terms of making sure we've got the right capacity and people supporting some of these really much needed changes. Because if we don't, we'll still be hovering around the tactical stuff and struggling because of benchmarking and the headroom is just not there. So let's invest in it.
Yeah, finish with Kevin.
Yeah, it's just a quick point. I think I'm probably sort of in the same space as Will, really, is that financial sustainability and delivering the ambitions that we've set out as an integrated care system are not incompatible. In fact, I think they're entirely complementary. We know we've got a set of arrangements at the moment which tend to, I guess, respond to poor health and often default into the most expensive option, which is secondary care. So actually, if we can work with our partners, the alliance and collaboratives, and think about how do we accelerate service transformation that delivers some of that, I think the better. So these are not competing priorities; they're actually completely aligned. I think the final thing I just wanted to say, and it links back to the comments I was making earlier about the running cost allowance. I think there is something about repositioning ourselves as an organisation and what is our business. And I think our business is exactly what you've just said, Kevin, which is supporting and enabling transformation in the system. That's our job card. So I think through that process, there is an opportunity to kind of reposition ourselves to do that work more effectively.
Good.
I just want to get a couple of three of those. The 4% saving we are trying to make in provision and the 1.8% we are trying to make in the place is not a risk-free endeavour, not least because of the process of industrial action in provision and the process of delivering the running cost life saving in the ICB. So we're a little bit foolhardy if we just assume that that's a done deal, responding directly to Richard's point. So there are risks to be managed there. We think we're managing them at the moment, but there are risks to be managed there. Just the industrial action, the impact on the income into the system associated with the elective recovery fund is really complicated. National College, NHS England are trying to create a compensatory mechanism that still incentivises elective recovery and elective work, but the calculus of that is blooming hard. So we understand, we think financial performance for April in this month with that compensatory mechanism. There's quite a lot of work going on in the bean counting going to veterans. It's quite a big income stream there, and the incentives are trying to be created to keep delivering elective capacity whilst noting that industrial action carries on. We've got to do this differently, and I think we'll start to describe that through the SLE conversation, and that links into financial strategy and financial transformation is really important. Just a little bit of a plea. I may nobble between now and the next meeting, perhaps Shahida, Leslie should think to do a little bit of the area I understand least well amongst many areas is perhaps that VCSE engagement in financial strategy. So I might just call upon colleagues to have a little bit of a conversation with me about what good might look like in that space.
Really help. I guess just finish a couple of key points there. Really challenging this year. And we'll get a better picture of the real nature of the risks that next time around the board. This year looks really challenging. Future years, we will not hit financial balance unless we work fundamentally differently in healthcare, with social care and with our voluntary sector. So the plan for the future can't just be a bit more efficiency, it's how do we do it differently. And for me, they were the two themes that we picked up very tight this year. We have to work differently in future years, otherwise we simply cannot hit financial balance. It's really helpful. Can we move on to the next agenda item, which is the 5-year forward plan? Will.
Thank you, Chris. I just want to start on that bit you just said there about working differently and thinking differently. So actually, that's a key tenet of our integrated care strategy. So we've already committed as a system to doing that, which hopefully should agree with. In terms of the update on the joint forward plan, you'll recall that both Marianne and I took you through the full draft plan in July, so gave a comprehensive update on the approach that we've taken, a very inclusive approach to developing the joint forward plan and the alignment with our integrated care strategy. I've referenced the paper 3s there. I'm listening to my chair around trying to reduce the size of papers, so rather than repeat that, we've made a link there. The purpose of this paper, if you remember, we got to a point where we went through that, went through the joint forward plan, shared with you the priorities coming out of it over the next 5 years, but we recognised that it was the first time we'd had a really well-developed full plan. So we said that we'd take some time over the summer to allow further engagement and feedback on the joint forward plan. So the purpose of this paper is to share with you feedback that we've seen and also to indicate where there have been any further changes to shape on the plan. Marianne has really helpfully put that into the 3 sections of that. So feedback from our public, Health Watch fed back quite well, consistency consistently on that as well, and also the feedback we had from our local authorities and other partners. So just to give you a flavour of that, I could just pull out a few points from that. That's helpful because that would just help you where some of the changes have been. Remember, we tried to develop a joint forward plan which is quite action orientated. We didn't want to develop another strategy for the NHS. It was practically what we're going to do, but not losing the sentiment of those key tenets, particularly around prevention first, focus on health inequality and certainly transforming, which, as you know, are really practical. So some of the feedback that we've had is quite detailed. So you'll see that there are some really detailed feedback to whether we focused enough on specific groups or specific groups that require specific support, like wheelchair access, for example. So where we've had that, we've actually reflected that into some of the detail within the joint forward plan. I also wanted just to remind our board that we also have an appendix to our joint forward plan, which is really detailed. Actually, it's almost like a work programme. It's just helpful to know that, because there was an expectation always that we would be able to respond to our long-term plan ambitions, and actually that's where you'll see them, as well as our NHS operational planning requirements. So I just wanted to reflect that. Our local authority colleagues really helpfully suggested some ways that we could strengthen our commitment to working with them in partnership, particularly as big anchor institutions. So there's been some reflection of that in working with partners towards the end of the joint forward plan, where we try to capture the importance of our partnership working and how that enables us to maximise on our potential and success of the plan. So we've reflected that. And particularly there is thinking about us as employers, and we had started this session, which part today is starting to bring to life some of the big enablers within our plan. Workforce is a massive enabler. So today, Christine and colleagues are starting to do that. And that will continue as well into the Integrated Care Partnership later on this month, where we'll think about that from an anchor institution perspective. I think our local authority colleagues have really helped us really think quite thoughtfully about how we do that as well. Our Health Watch colleagues wanted to really give us some feedback around the development of our outcomes framework. So remember, when we start to develop the integrated care strategy, we start to think about our outcomes framework. That work has continued, and you'll know it's quite detailed in terms of the outcomes framework that we've got. I think there's some thinking about how we really pull out, thinking about delivery of this plan over the course of 5 years, those outcomes that are pertinent now, and therefore will enable us to know whether the things that we're doing this year we are being successful in. So we'll do some further work. You'll note that there's an ask of the board to receive a more detailed update and insight on our outcomes framework and where that's got to at this next public meeting. There's some further engagement work to do on the outcomes framework. We're trying to make sure that we've had lots of inputs from lots of partners, and actually it's engendered quite a lot of engagement, which I'm really pleased about. Katie and Barbara are doing some work, particularly with our voluntary sector and some of our statutory partners as well, around how we can really broaden that perspective, particularly around building those insights and getting some of those insights from places where we wouldn't ordinarily coming from. So I think it'd be really quite rich findings to sort of see where we've got to with the outcomes framework. So I just wanted to highlight a few things from that. In terms of overall impact on the joint forward plan, I think it's made it richer. It hasn't fundamentally changed the direction or the priorities that have been set out in the plan that we went through in detail here. It's made it richer, and it's certainly made the more detailed delivery plans more richer in terms of the feedback that we've got. Katie would have been here today to go through the update on the engagement report. So you'll see that there's a link to the full report and the plan. But unfortunately, we've been one of the small number of ICSs that's been identified to work with Health Watch and the voluntary sector, so she's somewhere else. I think it's a positive thing. So just in terms of next steps, so it hasn't changed the tenets and the priorities of the plan. It's enriched it. We have started to sort of launch the plan. As you can appreciate, it's been out there as a full document. The board is asked to approve the final joint forward plan here today, but clearly there's some further work to do, particularly in terms of development of the delivery plans. And I think there's a a number of elements around that refinement which connect with Lee's updates as well, particularly in terms of how we ensure that the delivery is focused on what we need to achieve in terms of the outcome. So there's quite a bit to do in terms of the delivery of that. We will formally launch the joint forward plan at our AGM later on this month, and there are a number of supporting tools that will go with that. So you'll see already we've got an EV. We will have an animation to go with that. So I think the reason for that is actually how do we convey what's in the smart public? You challenged us with that. So I think that's where we'll launch how we unpack that and say, actually, this is what it means for you. So there'll be a plan to do that. On the engagement piece, so we started engaging, didn't we, way back, because we used the insights that we'd already got from asking our public and others what matters to them. That will continue. So there's a bit of assurance around that engagement work doesn't stop here. It will continue as we develop and refine our plans. So that's an ongoing commitment. And as I said, the outcomes framework is shaping up well, and we'll bring that back. We'll also, we asked if we could actually start to bring through some of those big enablers. So workforce is here today. Here I'll give a bit of a headline in relation to digital. We'd like to bring a really detailed update on where our digital strategy and transformation is going as well. So we've been asked that we do that in November. And I think, Chair, apart from just giving Kieran just 5 minutes, I think that's my update for today.
Oh, Kieran, hi.
Well, thanks, Will. So yeah, as just mentioned, there's going to be a bit more of a set piece on this in November, I think. So I think there'll be a bit more of an opportunity for a more in-depth conversation around the digital data and technology agenda. So today I thought it might be worthwhile just giving a couple of minutes of a high-level overview of the principles and the initiatives set out in the joint forward plan. I think fundamentally, in a one-liner, the ambition is to create a seamless and inclusive digital experience for the people of South Yorkshire. That includes the public, clinicians, ultimately to contribute towards improving clinical safety, supporting improvements in patient outcomes, building an insight-driven system so we can focus on prevention, support that bold ambition set out in our ICB strategy, and improving population health and reducing inequalities. To that end, I guess there's a couple of key principles that I just wanted to bring to the fore today. So one is we need to have a really strong focus on user needs. I think we need to be fundamentally user-centered in everything that we do in digital data technology. It's important that we listen to our public, listen to our clinicians to ensure that we deliver solutions that are inclusive, improve their experience and adhere to best practice standards. I think looping back to the feedback that we've got on the joint forward plan so far, one of the things that we've mentioned in our digital data technology plan is that we need to continue to foster and utilise our fantastic partnerships. That's what we've mentioned in the feedback. It's really important that we do that to minimise duplication and utilise those fantastic working relationships to deliver transformation across South Yorkshire. So I just want to pick up a few key initiatives, if that's okay. So the first one is we have an emerging data and insights strategy. It's currently being drafted. And again, going back to my earlier point, it's been a very user-centered piece. We've gone out, we've done the discovery work with a variety of partnerships across South Yorkshire to really identify what the needs of the system are. One of the aims of that strategy is to build an ICS data and insight alliance. So the plan there is to bring together the strong analytical community that can help furnish the analytical requirements of the system, those insight needs of the system. Hopefully this will include officers of data analytics in each place, which will bring the analytical community together in each place to bring their expertise to bear on place-based priorities and challenges. But also going back to the workforce points that we've made, really focusing our efforts on improving the data profession across South Yorkshire through communities of practice around advanced analytics, data visualization, data engineering, and so on. And I think some of those tools will be used fundamentally to move us away from building insights to actually using those insights to build foresights and to start using the data to look forward and to predict. And we've already started dipping our toe in the water
on that with the system coordination centre and the real-time data flows and the forecasting that we've got associated with that. I think from a digital perspective, want to continue the charge on the shared care record piece, making sure that our clinicians have got the information at their hands at the point of care delivery, so they can make really informed choices around patient care. We're aiming to build a patient-facing digital portal for the people of South Yorkshire. This will sit alongside the NHS app and give people of South Yorkshire access to clinical services, social prescribing, advice and guidance, pretty much to support that proactive left shift approach to health. And again, going back to the feedback on the Joy Forward plan that we've received so far, there was a comment in there about learning from what has worked well previously. So this piece of work around a patient-facing digital portal will learn from and build upon the good work done in Rotherham on the Rotherham Health App and the important contribution that plays to delivery of health and care in Rotherham. Of course, none of that will work unless we continue our efforts on digital inclusion, and it's really important that we continue to connect with our communities to understand their needs, to build an ecosystem of digital support, training, development, working in partnership across our places with a variety of colleagues, local businesses, colleges, voluntary groups, and so on, to ensure that the public have what they need to access digital health and care services. And I think another fundamental underpinning to everything that we're trying to do in digital data and technology is ensuring that we continue improving clinical safety and cyber security. We need to protect our data. We need to protect our systems as best as we possibly can. We do have a recently established cyber security forum for South Yorkshire, which is going pretty well. We're hoping to advance that into a cybersecurity alliance. You can see the theme here. It's a bit of an ICS-wide partnership that can develop that cybersecurity strategy for South Yorkshire and then work together to deliver improvements to our cyber hygiene across South Yorkshire. I guess just to wrap up, Chair, the digital strategy will need to be refreshed over the next 12 months. So again, it is a very user-centered design process. We'll reach out and start looking into that. The ICS data insight strategy will be hopefully in draft very soon and released for engagement. And just to make you aware, our first South Yorkshire Cyber Security Summit, lots of S's in there, will take place in November, which will be hopefully kick off our cybersecurity strategy and deliver against our.
Thank you. Any questions? I've got Leslie, then Shahida. Leslie.
Thanks to Will and Marianne and colleagues for doing that update, and it's really good to see that we've been able to flex our plans around bringing in some of the comments from colleagues across the wider partnership arena and still maintain. So it's really encouraging that it's not thrown us completely out. It's actually, as you say, Will, enriched what we've got going on there. So I think that's really positive. It's also really positive to see that update of the report around the engagement work. And I did have a look at that in a bit more detail. I especially like the "you said we committed" part of the document, and I like the easy read version as well, by the way. That really spoke to me. But that "you said we committed," I think is going to be essential moving forward, because it starts to make concrete what this really means to people who live in South Yorkshire. Rather, with the best will in the world, you read the strategy and it's a bit highfalutin and a lot of NHS speak and all the rest of it. But that actually is, well, what then? So what's going to change? And I wonder whether there's any plans to do more comms type work on that, because I think there's a real opportunity there, both in terms of making more concrete for our public what we're about, but also being held to account by our public in 12 months' time. If we've kind of made public statements about those commitments, we come back round the loop on those. So that was my question, really.
Do you want to respond on that? I'll bring on
Thanks, Leslie, for highlighting the "you said we did," because actually it is on our website. I've forgotten to mention it. It's a really critical part. And I think it does start to crystallise our sort of commitment to actually what we're about. Yes is the answer in terms of doing more comms on the easy read. So that's part of what we're trying to develop for the AGM. So we've got really clearly, so you can track it back to you know, what you can expect as a resident in South Yorkshire from the ICB.
I've got Shahida then, Lee. Shahida.
Thanks for your side, really. Just really quickly, I think it's not necessarily a gap, but I think it links to the comments point that Leslie just made, and it's around elected members and the whole political theme in South Yorkshire. I think if we can share this in a more kind of concrete way with that audience is going to be vital, because I think, especially when we're connecting to the public, a lot of us, we're not in elected roles. And so I think in terms of accountability, in terms of engagement with community, if we can get councillors, MPs, you know, to have some sense of understanding about our joint forward plan, I think will help in other areas and other arenas as well. Because especially where there's kind of cross-sector partnership working, I know across the political spectrum, you know, different councillors get behind different things. So I think there's you know, opportunities there for influence and leverages that could kind of help us to do some that kind of transformative stuff that we're talking about. So I think it's brilliant, fantastic piece of work. I love the engagement. I love the fact that we've got loads of stuff coming through. It just worries me that we are not an elected body. However, there are elected members out there that I think they have a function that we need to be engaging with. Otherwise, we're at risk of, yeah. And then just something on the data analysis. It's more of a plea, really, and that is about enabling data insights and analysis to connect with communities in a way that not only I don't want it to be extractive, so it's not that kind of, oh, let's go to communities and you tell us what, but actually one of the things that we discovered during COVID was that a lot of our institutions right across South Yorkshire were really, really heavily reliant not only on our BCF sector colleagues, but those in the grassroots to give them that kind of sector-led intelligence about what was happening on the grassroots. But a lot of the gaps within that was they were then coming back to the system and going, well, you give us the data and tell us, you know, the bits that you're struggling with. And a lot of those data systems didn't speak very well. So there wasn't a universal language in terms of data. But then when the community organisations and partnerships were asking us for data insights around demographics, around population, around whatever it might be, we weren't able to give them the data because none of it. So I think it's more of a plea just to say that I think it's fantastic that the alliances that are building up, but I think it needs to be a kind of, the ecosystem needs to think about what do we do with that data and who is it useful for, not just us as a system.
Go on, quickly,
very quickly come back on the elected members, if that's okay. So I think that you mentioned it's really important. That absolutely came up at the Joint Health Open Scrutiny Committee. So whilst it was recognised that the approach that we've taken on this is really inclusive and engaged in lots of forums where elected members are, there is something about seeing elected members of the group themselves, and therefore was an action that we took away. So we absolutely are responding to that, yes.
I've got Lee and then Kevin.
2 points. Statement one, I think it's in really good shape now. Well done. I think we've done this process justice. The two thoughts that were coming to me while you were talking, Bill, there was point one was how do we put this more centre stage now in terms of, if we're not careful, that outcomes framework work is so important because it defines what we're about as an integrated care partnership, and then our accountability for delivery of those subset of those things is one of the thoughts I was having. Then the second thought I was having was about one of my more recent career failures last year when I was trying to persuade SLE to start our South Yorkshire planning process earlier than we got some national operational planning guidance related to the NHS. I think I might have another go at that conversation at SLE, because I think there's something about what is the work that we are trying to do as an integrated care system that will make sustainable elective recovery and other things before we have slightly bounced into a very NHS-centric operational planning round. So I think we might need to think through how do we tee up that conversation for SLE again next week, and I'll try a bit harder to go, how do we build out the place-based plans in terms of what year 1 and year 2 looks like, which makes everything else more sustainable in terms of our broader transformational objectives. So they were the two things I'm thinking, but I'll shut up now, Chair, and sorry, I'm not enabling a break.
I think the last point's a really important one. We don't know the exact figures that will appear in the planning guidance next year, but we know what the planning guidance is going to say, so we could be preparing for it now. I think that's a really good point. And the margin, the figures will be 0.5% different. I'd be stunned if it was more than that. Kevin.
Thank you, Chair. This boils down to a significant commitment from us as a board to the people of South Yorkshire. And I've read from Help Watch those concerns that we rehearsed earlier about deliverability. We've asserted today that we're confident that they're entirely compatible. Can we therefore take the opportunity at our AGM later in the month when we launch our initial plan to illustrate confidence with some examples of how it would work to bring it to life? Because I feel passionate that if we're committing to this, it is a commitment and we will be held to account in years' time. So let's build on that confidence and show some examples of how entirely it is confident.
It's a really good example of how we could use the AGM. Will, Kieran, thank you very much. Really helpful. We are now going to take a short break. It is 11:36. I want you back sitting down at 11:50. Okay, did you hear that? 11:50. I suppose to be shouting at you. It's 11:50. A short break of 14 minutes. Okay, can we start, please? So just to explain, start be quiet, can I just, we've got a part 2 meeting, as Gavin explained, we have to be quickly, because there is a quite important meeting at 1 o'clock, I want to make sure the execs are clear for that, and that's clear for part 2, that's just a note for everybody. Okay, thank you. Silence, okay, item 12, NHS workforce plan, South Yorkshire. Christy.
Thank you. So this is the long-term workforce.
Yeah, sorry.
With the South Yorkshire sort of field. So the pack that's in the paper is pretty basically the same as what Gavin put in his sheet executive. It's the outline of what's in the long-term workforce plan and the 3 particular areas of focus around that. So there's no particular different thing, but I think probably just go to the actions taken slide at the end. So what we've done so far since that was published is we've had a discussion which is really helpful at senior leadership. What does this mean for South Yorkshire? And we did try to look at some of the stats. Now we've had nothing yet around what does that mean about the South Yorkshire. So what we've done is our best to apply sort of weighted population angle on that, look at what the numbers might be for South Yorkshire. Okay. But at the time when we did that in system leadership executive, it's kind of a basic analysis, but I don't think it was really telling. So I haven't included that here yet because I think we need to do quite a lot more work on that. We are just about to get a more detailed understanding of university starts and various other things as well. There's also something like what is our starting position as well. So we had a really interesting discussion at System Leadership Exec around the 3 areas there, I think, and so there is work for us to do, and this isn't all about supply, is it? It's also about retention. So we've got to have a sort of a fairly equal focus across all of those 3 areas, and then the reform element about what are we going to do differently. And we'll talk a bit about transformation today. So I think that was literally the start of the conversation around, okay, so what does this mean in South Yorkshire? So as I say, we are waiting for some further information from NHS England about what this means for North Eastern Yorkshire and therefore what this means for South Yorkshire as a sub-region of that. But crucially, we're also waiting to understand how the funding might flow. Now, I am assured that the money is there as specified, as Gavin said. You know, the money has been committed to. What we're not clear is how that is going to flow through to support the delivery of those elements of the long-term workforce plan in South Yorkshire. And we do have some fairly urgent requirements around that because a lot of our infrastructure in terms of delivering elements of the plan. We're supported by Health Education England, which is now in the NHS England, and so all that operating model change is impacting in terms of understanding that play. Obviously, there's a heavy focus on the NHS in the long-term workforce plan, and it will become a key focus for people workforce and going forward. But this isn't the only thing either, and actually what we need to do is be mindful that we are also having to focus on the entire health and care workforce in South Yorkshire. So I think the key risks for us, if we just go into the key risks, just on that point, in terms of cross-sector working, I do actually have a voluntary sector member on system delivery in my delivery group now as well, representing the voice of the voluntary sector on that. So I think that would be really helpful in taking us forward. So just the key risks around, we do know that cost of living is having an impact on student numbers, and I think we'll see that when we get the final figures through. I know that the assumptions in the long-term workforce plan is that we are always oversubscribed for these courses, but the reality of people taking up those places now in those universities in the traditional way is changing. And many of our courses were moved to clearing during September, which they wouldn't normally have had to do. We've also got to triangulate, as Lee said, the workforce elements and all of the growth that is specified in the plan with affordability in South Yorkshire. So this isn't just, yes, we can create loads of people coming in, but to afford. So that is absolutely key, and obviously we're working on that at the moment. We've got to understand how the operating model in NHS England will work with the ICB operating model, who's responsible for what in that space, and that is again work in progress. And then we've got to understand how the programme investment risks will manifest themselves. And this conversation was going on People, Workforce and Culture Committee. It has gone on the issue of it's not actually a risk, there's a short-term issue.
I'm assuming that we're going to have, or the system's going to have, for instance, conversations with the universities about a different type of training. At the moment, we simply don't know how that's going to happen. Is that what? Is that?
Yes, that's right. Yes. So we, at the moment, I think we're still waiting for the sort of national programme leads for each of those 3 areas to operate, to help us operationalise. And we're fully expecting to be part of that discussion around how we do.
Because presumably we'd want to be talking to our universities early, getting on pilots, all of that stuff we'd want to be doing.
It's not just universities.
No, I'm used to that.
There's a significant increase in apprenticeship roles. There are opportunities for us to do things differently and to widen access to that kind of training that perhaps wasn't available to people before. So there's huge amounts of opportunity in that field. And we just at the moment, just at that early stage, I think, of understanding how it would be operational. Now that we're already having conversations, and when we're in system leadership executive, it was clear that a lot of colleagues having conversations with university partners. In fact, indeed, our university and colleges are also part of the delivery group, so their voices are heard, and so we'll be able to influence that together. No, I mean I didn't really, I can present to you what we think is the case, but I think it's probably just better to wait as a board for us to be able to get more information on the South Yorkshire position before we go into the details of the numbers. I just thought it would be helpful to give a sense of an overview and some of the actions that we're taking at the moment and some of the potential risks and issues that we've got.
Okay, that's really helpful. I mean, in terms of the board, we'll see this steered through the Workforce Committee.
That's right.
Okay. I mean, I think when we're clearer on this is what we need to do, I think the board on one side, this is such a fundamental issue that the board needs sight of that pretty early. But I understand that at this stage, we don't know. I guess the other thing we'd all say would be, whenever they do this, I've always seen pilots operating nationally. I think we want to be in there. We want to be at the front end of this. We've got all the way through the theme of today, we've talked about economic regeneration, workforce, disadvantaged communities. This is a real chance to do that. And actually, the apprenticeship's a really good example. How do we get, not just have more apprentices, but how do we go out to some of those communities to get more apprentices and make a difference on health inequality? And I don't want us to be pushing that angle as much as anything else, I think, because that's absolutely consistent with our long-term strategy. Really helpful. We'll see. I think this is just tape marker, really, isn't it? I don't know what that is, but it worries me. It did sound like a countdown, and I was beginning to worry. Moira.
I just wanted to make one quick comment. I know obviously this is just the outline, but I think one of the things that we really need to focus on, I think this was a discussion we had earlier around refugees and bringing agents, what can we do now to retain existing talent and people that we know are already in South Yorkshire that can continue to make a big difference. And also, we know that staff at all levels are under significant strain and stress, and what can we do to actually enable people to remain healthy at work? And I know Christine already doing a load of work on that anyway, but
I agree, really important. I mean, there's some story. Here's a guy who's medically qualified. How many bloody hoops does the system make him go through to practice when we wish it was done? It's extraordinary, and no offense, slightly depressing. Christine, thank you very much. That's helpful. The next item is yours as well, the ICS Quality, Diversity and Inclusion update.
Yes,
please.
Thank you. So I think this is here twofold, really. One is just to try and show to yourselves as the board the work that has been going on in the space of the integrated care system around equality, diversity, and inclusion. But also to put, I don't know, hopefully you've read to the end of the pack or at least read the cover sheet, but there are some challenges in there, so I would like to just go back to those before we move on. As a segue into this, we've talked a lot, as you said, around people needing to be able to access our workforce from a whole different parts of our population, and those people that are here who are refugees and those people that we bring in, recruiting from abroad. But we also need to be able to act as a good anchor employer, and this really does link to our commitment to the integrated care strategy about valuing and recognising our entire workforce and increasing the diversity of that workforce. We won't be able to retain people. We find it hard to get jobs and stay in jobs if we are not the most inclusive workforces and workplaces that we can be.
Great.
So we can have fantastic employability programs happening, but the environments that people then come into work need to be places where every colleague can thrive. And so it's really, really important that we focus on equality, diversity and inclusion and belonging, so that we can create that sense belonging in South Yorkshire and feeling you can bring your whole self to work. So I just wanted to show this because I think there's a huge amount of activity, and Ali Bishop, who is our South Yorkshire lead in this area, has recently left us to go to West Yorkshire. And so in a way, this is a way for us to sort of celebrate some of the work that she's been able to achieve as well. So in terms of just summarising the progress, we have got a set of strategic objectives that we have as an integrated care system. So these are in here. So this document is a slide packet. It's quite interactive. There's a load of embedded documents. But if you struggle to get access to any, let me know, because sometimes with the PDF they don't work as well. So we can share those. But we do have a co-production group that developed a set of strategic objectives and principles. We have a senior responsible officer now, as Kirsten Major, who took over from Catherine Singh when she left. So we have really good, strong governance around that and leadership. And I'm really pleased to say, Piers, I hope you don't mind if I say that we have created a new Policy, Diversity and Inclusion Leadership Group for South Yorkshire, which is board level. So there are board level representatives on that group, and will be chaired by Piers as the Integrated Care Board Chair. And I think that demonstrates, really the strongest possible leadership commitment that we've got to this work. So the paper describes a whole range of really fantastic pieces of work that we've got. So I won't go through all that in detail, because I'd like us to focus in on, so what does this mean for us as a board? Well, we'll be part of that leadership group. So Piers is chairing it. I've got the executive senior responsible officer for South Yorkshire, so I'll be there. But we also have other board members from here as well. So, and Kirsten will be attending this group with her SRO hat on, and somebody else from SDH will be on that group as well. So I think that's really important. We've got an equality, diversity and inclusion improvement plan from NHS England, and there are a set of high impact actions in there which are described in the paper. And that does ask everybody to have an equality objective. Every board member have an equality objective. So what I'd really appreciate is your thoughts around the challenges. What will your objective be? There's a lot of us around this table. If we all pick an objective that is actually something that's really impactful, we might not know what it is, and if we're the chair of the network, maybe we could ask our network chairs if they've got any thoughts on what that objective could be. It could be something that we're really passionate about, but if it's something that you could demonstrate something, that's a lot of impact just in this room. And then if we multiply that across all of the NHS trusts in South Yorkshire, and we use our new leadership group to get sight of what's happening, actually we could make a massive amount of difference just as a group of leaders before we even step into any of the other high impact actions. So I would really ask everybody around this table, if you have a look at your objective that you've got around you, is it specific? Is it measurable? What would it say? How could you use that if you were asked that question? Because I think this is also designed to help you as well. What have you done? Then you can answer that question with confidence, and then we can make a real difference as a community of leaders and as boards. So that is one of the key challenges in this paper that we wanted to make to you. The second challenge was, this is a space for humility. So the other ask is for us to be leaders and recognise the need for us to be humble in this space. And actually we might not know enough And I was really struck by meeting somebody who is an academic in this space, who reads every day more and more about change. So the fun thing about us not thinking we know everything or know enough to get by in a conversation, but so there's that discomfort space, I think. So I think that you can do your objective around something you're passionate about, great. Or maybe there's something around where's the space you do feel quite uncomfortable, and could you actually do something for yourself individually in that space? And then the third ask of the board is microaggressions is an area that we have our least developed in understanding how to manage. Our policies, our HR policies are way off. Our statutory manager training is in no way skilling us up to be able to understand what that is, understand the impact of the call down, recognise it when we do it ourselves, be able to have that conversation with someone that can be quite uncomfortable. And so really, but as leaders, if we spot something and don't say something, then that's actually going to be even more challenging for people that work for us. So we will put in place a lot of activity around microaggression, because I think this is where a lot of things, people feeling that you belong and you can work and thrive in a workplace, will be impacted by day-to-day conversations and interactions with people. And we can't formalise all of that activity, but we have to be confident in order to be able to say something about it. I think we've got a really strong leadership role in that. So those are the three things that Ali and I really wanted to share. So we wanted to share with you the work so you can see it, but also really say the so what, now what bit of this is what can we all do as a board together and as individuals in that.
That's really helpful, Christine. I particularly found the last bit around what do I do and the microaggression stuff. I think it's really, really helpful. A number of people, David, then Leslie, and then she.
So, though Ali left us last night, she shared with Christine and I that she's actually had an article published in the BMJ, and it was about networking and other important requirements for women leaders in advanced senior leadership positions in the NHS. I think that, credit to her. Yeah, I said to Christine, I think we should be taking that for our people workforce and culture programme, because it's a fantastic piece of work, and I think it gives us a bit of a mandate to commit to something. I suppose while I've got the mic, I mean, the reason why I'd asked could I leave at 1 o'clock is the Inclusive Cultures Programme. It's the second wave of that, and I think I've signed up for that. So that's kind of, I'll put out there straight away. That's my commitment. I think I committed to that when I got my interview with Pierce. Just to take a bit of time to get in, to get the time to do it. But there we go, I'll just put it out there for mine. So,
thank you. Leslie, and then I've got Shahida.
We did consider this report in quite a bit of detail. The People Workforce Culture Committee, which is really helpful to kind of be able to go into it in a bit more detail there. And I'd really support the recommendation around a more proactive approach by the board. I think it's key to this in moving us forward. And one of the things I raised was that there's a lot of good work gone off here, and that's not to take away from it, but quite a bit underneath this around need to look at disability, particularly around acquired disability and how that impacts on people's lives and their continued ability to work or not to work, which kind of takes us back to that wider, how people can kind of lose out in their lives if they can't work because of a disability. So I've kind of already spoken with Christine about perhaps picking something up from a personal perspective around that whole issue and looking at whether there's something I can usefully do around that.
Really helpful. Shahida, no.
I just kind of wanted to, there's been some fantastic work going into this, and I think Christine's point about, as a board, each one of us taking an objective, and Leslie's point about being proactive. But I just wanted to put out there that it's absolutely okay to feel uncomfortable, because sometimes we don't. When we're talking about EDI, it kind of gets into a really nice fluffy conversation, or it gets into that bit where everybody goes, oh yeah, we really need to do something. Well, actually that requires real hard work. And when we talk about humility in leadership, it's actually humility in behaviours as well. And I think there has to be, we've got to name the elephants in the room. 1, some of these conversations are difficult. 2, they're going to make you feel uncomfortable. 3, it is not the responsibility of your colleagues with protected characteristics to make you feel comfortable. It's not their responsibility to do that. So don't look at them to do that for you. Certainly question, engage in conversation, have a discussion, learn more, gain your knowledge, but it's not their responsibility to make you feel comfortable. I think that's really important to say, because you can't do EDI work unless you go on a journey. And I know that there's colleagues around the table that will share this frustration, but quite often our colleagues with protected characteristics are looked at to kind of circumvent the journey. It's like, just tell us, mate, just tell us how you want us to be. It's like, no, you've got to learn it for yourself. I think that's really important. And I think going back to the leadership, EDI leadership group, I think that's going to be a really interesting space, because again, I think as an ICS, we have an opportunity to model not just aspirations around inclusivity, but behaviours that will say to other people, here's a really clear statement of intent about how we are going to progress transformation in business in an inclusive manner. And therefore, you've got to start walking this walk with us. And I'm just saying that not to be controversial or anything, but as South Yorkshire, we are quite often paralysed into inaction, the fear of not wanting to upset other partners, because we're going on a transformation journey and they're not. And so I just think we've got to be, again, brave about some of this stuff that we do. And it, again, just to finish off and say, it's absolutely okay to feel uncomfortable.
Really good point. Really good point. Lee?
I'm very happy with the immediate actions recommended. Absolutely am. I think there's this really interesting balance with our staff networks and the allies on those networks, and trying to foster what's the right work plan for them. So we've set these things up. I mean, we're trying to support them. We're trying to do the strong advocacy for them. But almost there's this kind of interesting dilemma about, you don't want to foster, well, here's the work programme from the LGBTQ plus about what we're going to do around making workplace better for that group. But I think we probably do need to see something back here that says, how are they going? And how do we synthesise the work that's coming out of those staff network groups? That was one idea I had. The other idea that I had is part of my SIPA role, we did some really good training on inclusive decision making, which really challenged biases around board tables.
Okay.
And it was really impactful. And sometimes I enter these sessions and I'm cracking on, I'll learn at the end. But actually, it was 2 hours where I went, if you just think about the number of biases you come with into the decision-making role, and it might be a specific action for the board.
I've not heard of that. I'm interested in that. Can we talk offline? Because that sounds really interesting. Lisa, did you want to come?
Just very quickly, I think it's a really, really useful piece of work. And I think if we have the EDI strategy embedded in everything else, it works better, and having that buy-in from the board lets people know, people working for the organisation know that we're taking it seriously. I just wondered how you were going to sort of get feedback from those people. Is that going to be a continuous thing? Will they be able, is there sort of a pathway that they can report to, or someone in charge or responsible that they know that they can look to if they're having issues?
Christy, do you want to respond then? I'll ask Gavin to finish up before we move on.
And so we have a range of ways of people that can speak up if they don't feel that they're being heard. But I mean, in terms of the feedback loop around activity, yeah, I mean, that's one of the things that we would want to use our staff networks for. And in terms of my delivery group, I'm trying to get really good on there, do you know what I mean? So people can actually talk about the reality of it. But I'm sure we've got much more to do there.
Just briefly, just absolutely support this, and I think it's critical that the board actively gets behind this. But just to be a little bit challenging, I think we would all, everybody around this table would identify with stamping out discrimination. I mean, it's in our DNA. There's a risk that becomes warm words unless it's supported by measurement and data. And if you look at, I mean, to be frank, if you take race, for example, look at our workforce race equality data, your point about humility is well made, because actually that tells us we've got a long way to go. So I think there's something about visibility at the board about what's the reality of the current state, what's our ambition in terms of the future state, and how do we track our progress in quite a determined way.
Thank you, Chrissy. Really helpful. I mean, I think this is something we have to keep regularly. There is something about measuring this and making a difference rather than just being warm words. I think you're right, Gavin. And maybe the workforce committee can help us think about how we do that, because I don't want this just to be the one words. It's going to be more than that.
Yes, if I could just say, I mean, I think Gavin, when he talks about, things being absolutely aligned, this isn't a nice to do. This is about retaining and being able to attract workforce in a way that we've just described. And our workforce is our population, so the more that they can work and thrive. So this isn't to add on. This is cool. So I think it'd be good if we can have our agenda so that it reflects the coordination.
And it's interesting when we put up that bit about the committee. I think people are beginning to get that. This is not an add-on. This is about everything we do. You can't be successful in retaining workforce or attracting workforce and not really be sensitive on EDI. It's not possible. They are the same thing. Christine, thank you very much. That's really helped. Agenda item 14, which is the integrated performance report, the IPR. Who's leading me into this?
I'll pick this up. So, I mean, to be frank, on financially, I feel we've done that. So we're not.
Have too much for good thing. I'm fine with that.
That's one way of describing it. Then.
Perhaps if we just go through the major areas of focus. But Kathy and David, any particular things you want to escalate from a quality perspective? So,
escalation or sharing with the board, Gavin. Yes, I've got 3. So we have the Cancer Alliance board on Friday. I think we brought before about oncology workforce being a particular pressure in South Yorkshire. So fragility remains, but the service continues providing the service for people, and actually by utilising in-source remedy and providing additional clinics at weekends and that we are providing the service. But there are other. So that was breast non-surgical oncology, but we have got pressures in urology and short term we had in radiology. We've benefited from some mutual aid support for children's radiography, and that's been provided for a number of months now. We've asked for an extension, and that's been agreed that children who require that particular treatment for their cancers will be that will continue till March of this year. So that was the first thing, oncology. The second thing we picked up is industrial action, and although we talked about the financial impacts, we can't shade away from there are quality impacts on there, because when you look at our performance for people who are waiting for operations and for treatments, they undoubtedly are impacted upon. So I think we should acknowledge that. And then the third thing was we've referenced the winter plan, which will be submitted on Monday after it's been through the UEC Alliance board. That really follows on from the national publication of the UEC recovery plan back in January. And what we've done as a system, we've prioritised in each of our places 4 of the 10 high impact measures, and they very much make the basis of our combined plan that we'll submit. Without going into Joe's work, we are seeing some continued improvements with UEC across all of the parameters, but we are stretched on some days. So we have a surge, we see some deterioration in that. But progress continues to be made with a particular focus on discharge. So Gavin, maybe the 3 things that could raise there.
There's just a couple of things I wanted to touch on. I think probably in relation to the conversation we had around the learning from the Letby case, but other national reviews over the last 12 to 18 months. We are in the process from an NHS perspective moving over from kind of formal reporting of SIs and incidents to something called PSERF, which is more of a thematic review of processes, which is why we're not kind of reporting that data currently into the board. But I think there's some real risks associated with that based on kind of what we've learned over the last couple of weeks, and I think a little bit more historically. So there's something that I think it's probably important to bring back very quickly to board around PSERF, how we're going to make sure we're still sighted on some of that safety data that's coming out of organisations, so that we can at least kind of have a flag around where we might need to do further work or further interrogation. Second element I just wanted to pick up was around maternity. We've obviously had the national maternity plan we've been working through as an LMNS and with our organisations
What does that mean for South Yorkshire? What are the areas we need to focus on? How does that link into our maternity equity plan? And we are due an update on that to the board. I think it's either in October or November. So just need to make sure that we've got that mapped in. But I think it's important to kind of highlight, and I have done previously to the board, that we are still a bit of an outlier from a stillbirth rate perspective in South Yorkshire, which is a concern. We've been doing quite a lot of work through the LMNS in relation to that. Doncaster and Bassett Law and Jessup Wing and Sheffield have been the outliers. Doncaster have done a really kind of roots and branch review around that. They've put work in place, and that stillbirth rate is starting to come down. I'm not sure that that's the same from a Sheffield perspective, so we need to pick that up again through the LMNS. And Leslie and I had a conversation at the break around how we bring some of that assurance through quickly to do that work on behalf of the board rather than trying to do that here. But I just wanted to flag that as a concern, really. But there is work in hand, and Rich and I've had a couple of email conversations even whilst we've been on leave around that, but also kind of neonatal data. Now we might start to pull that through a little bit more purposefully.
Can I just ask something on that, please? Excuse me, which is around what you said about Sheffield. The first question I've always got for a board is: are the board of Sheffield aware of that? Are they worried about it? Because that's where I would start at saying, because if they are and they're doing something about it, I feel somewhat reassured. But if this is a concern here and not there, I'm not reassured. Does that make sense?
Yes, I know you kind of chaired the quality board whilst I was on leave.
So, I mean, I think what I would say is, I think there's a lot of detailed work looking into what might be driving a position, whether it's case mix or other factors. So I think actually there's a lot of focus on this within STH. I think it's just about seeing that beginning to move the dial. So I might, based on the conversations I've had with STH, I think they're well on it.
Richard, sorry.
One of the things that myself and Kathy have been talking about is reality of the data that we have tells us a story. How do we make sure the story is read?
Yes.
That does mean that where a chief executive like myself is the chief executive program of work like the LMNS, how do I make sure that my other colleagues are also cited on the things that I see? Because I see a wide report and a big range. Standardising the reporting of our single delivery plan and 10 actions. But then what do we do? Do we share that with chief executives as part of the acute federation, or do we rely on the chief executive receiving it as part of the board? Is your yes. So I think we are still working through that, because the reality is you should get that anyway from your monthly board updates. There's all acute trust board receives maternity updates as part of the requirements and way action plans. And they're pretty much standardised now on still basis, pretty much in that pack in terms of the information over time, the information current. So I think it's a nuanced thing now about making sure that we're not missing anything in that way that we aggregate up and down. So risk up, risk down, and everybody's cited on the same risk. I think the change has been that all of the trusts now cited on each other's risks.
I was going to say, I think that's so. If I look at when I was chair of a trust, I'm sure I was told about my stillbirth rate. I'm not sure I was told about where I stood against the other trusts, in my case in Lancashire and Merseyside. Actually, that is a really interesting and helpful, because if I suddenly look at it and think I'm worse than anybody else, I want to do something about it, because it's not always apparent when I see a stillbirth rate, because actually these numbers thankfully are quite small. They can vary from month to month. What I really want to know is if over a sustained period I'm different than everybody else. I want to know that, because that's a really significant figure. I just want to make sure our boards see that. I sometimes think boards get information on their position on anything, and it could be on emergency care or ambulance rates, and then they can get a figure that says, "Don't worry, it's bad everywhere." Yeah, but I really want to know where I stand against everywhere else, because that gives me something that enables me to say, I actually should be worried about here. So there's something for me about, it's a bit superficial and I'm a chair, so I will be. But actually, I think that reassurance, I want reassurance the board see that. Because actually, that's the board beginning to take responsibility.
I'd be fairly confident that the boards do see it.
Okay.
And increasingly we see each other's, which I think brings that added strength. And increasingly we look at each other's in terms of learning, or shortening learning, because clearly Stillbirth's influenced by many, many things. South Yorkshire's got a number of factors that mean that the challenge is possibly one of the bigger challenges, but that doesn't mean we can't learn from each other. I think one of the things system working is doing is allowing us to foreshorten that learning by sharing each other's information, because it is really, really useful to sort of keep doing the work.
Okay. Anything else on quality, sir?
Okay, thanks for that. Christine, anything to add on workforce?
Well, only just to flag, unfortunately, there isn't workforce there in this integrated performance report. Again, Kevin and myself and the team are still working on trying to get a more accurate solution that we can provide. So at the moment, my data is monthly, whereas financial data is month 4. The only thing to say is, as at month 2, we were above plan on sickness absence, and we were above plan on agency and bank across South Yorkshire, and I think that's not unsurprising, but there's activity taking place in both of those areas. Apologies, it's still work ongoing.
Thanks, Chris. And Joe, headlines on operational delivery?
Yeah, David's covered quite a lot of it off. So the only things I would flag is we've changed the cover sheet for our IPR report, which I hope is helpful. The reason we put those 3 things on UEC and anti-length is because the scrutiny on those 3 areas is intense now, and it's probably going to intensify over the next 3 to 6 months, which I know won't be a surprise to many on the table. Just some of the key headlines around urgent emergency care. When the winter plan came out, we had some clear guidance about the system controls, coordination centre, which has been changed to, and our escalation framework. So we've got a system workshop next week, just to make sure we're all aligned around winter and escalation, which I think will be helpful. On cancer, we've had guidance out around the revision in the standards, so we've gone from 10 to 3. I think that will have a detrimental effect on the 31-day standard, but it should, in the longer run, it's the right thing to do with those 3 standards going forward. And then on electric grid, we are doing well, but it's quite fragile. The systems are getting industrial action, or we have a bad winter. It will potentially knock it off course. Again, NHS England, NEY, chief executive to explore that in no more detail. Thank you.
Thanks, Joe. That's it.
Kevin?
Thank you, Chair. I think it's a question for Richard and the acute collaborator on elective care, because there's promising signs on the over 65 weekers. Well, there's also a growth in the over 52 weekers, and therefore I assume a growth in the total number of incomplete pathways. It feels as though there's a big problem coming, and just some sort of assurance from the collab that actually, notwithstanding the risks that you've articulated earlier about industrial action, actually plans are in place to get us to where we need to be, or is there a problem stored up for next year? And that's the question.
I mean, I'm happy to comment on that as well. Richard, do you want to go?
I don't mind going. I'll go if you want. Yeah, I think you're right, Kevin. The acute and supervisors are concerned about that particular challenge, because the referral rates are particularly slowing, which means that the size of the waiting list, if anything, it's growing, despite our best efforts to deal with the longest waiters. And so whilst we're tackling the longest waiters, it means that the previous balance of people entering the waiting list being able to take them off quickly, so that the actual curve doesn't move. It's much, much more difficult, because all of our resources are going into, for the right and understandable reasons, that people will be waiting longest. Now, I think the work has got to be multiple, so I'm sure that Leon would agree that in reality, we've got to make sure that the referrals received into hospital that require being seen and receiving treatment are done quickly, because a number of those patients are better served by treatments provided elsewhere than the acute hospital. The quicker we can get to those patients, the more we can look to reduce the waiting list and make sure people are receiving care quickly. What we've then got to do is maximise, I think, capacity within the total system to deal with the total system pressures, so that actually where we can, dealing quickly and efficiently with patients, by using all of the trusts in South Yorkshire, all of the ISTs, all of the capacity we have, including capacity with primary care. And that does mean things like outpatient, because remember, a great proportion of the way outpatient work. But in reality, the problem is only going to get better if and when we are able to ensure that the patients get seen and treated when they're booked to be seen and treated, to get seen and treated most effectively to waive their needs. And where that is hospital, that the hospitals have the capacity to meet the demands. And that is the work that the Federation is doing. Is very much cited on this. So we are hoping that the work that's going on everywhere will mean that we can gradually reduce the waiting list that's coming up to 52 weeks, so that they don't become patients who wait longer than a year next year. But it is very, very challenging. Gavin, I don't know if you want to say anything.
No, well, I suppose I was just going to say that in terms of hitting the 65 weeks target by the end of March, the total cohort of patients that will be waiting on the 65 weeks by the end of March is coming down quite well. So I think that's the good progress that Joe describes. But you're absolutely right. I think there's a challenge coming along the line, because this isn't about just treating the longest waiters. It's about a bell-shaped distribution, which is creeping along the x-axis. So I mean, sorry, that sounds like gibberish. So, but you're right. Yeah, you got it. So I think there's a problem coming down the line, and I think that if you take something like industrial action, for example, all of that is not helping. That's adding to that challenge. So clearly we're focused on getting to where we need to be by the end of March, but we've got to be thinking beyond that, because there's a challenge coming.
And it probably, Chair, it probably plays back to the earlier discussion about that adding patients onto the beginning of the list is the issue we need to tackle.
Yeah,
and takes us back to the transformational piece of doing things differently.
Well, I think also it's that middle bit, because if diagnostics are an important performance of the case, diagnostic waits are long, then that means any treatment other ways are long. So this is a multiple complex jigsaw puzzle where we've got to make sure that we actually can see the sort of picture and putting them